Starch iodide test positive. This is the iodine solution that we have placed. इसके ऊपर हमने starch का powder लगाया हुआ है. Now the patient is going to sweat. I'm going to ask the patient to eat and this discoloration will be noticed. It's a starch iodide test. For a true cut, I'll be using a 14 gauge needle. So this is the baseline data in terms of needles that you need to know. Foley's nasogastric tube, your ICD, Robinson's, everything goes in your passive drainage. Now when we talk about the active drainage, they drain due to pressure. When you have to do a bilateral thoracotomy, you'll put an incision that is called as the clamshell incision. NUS procedure is another variant that you can do across here. So let's start the discussion. We'll take one question at a time and then उसके ऊपर धीरे-धीरे concepts build करते हुए चलेंगे. I'll also tell you how to analyze a question, how do you basically try to get to an answer, कैसे eliminate करेंगे, ये सब चीजें देखेंगे. ठीक है? चलो. So हमारे पास question number 1 है. The question number one that we have is a 40-year-old male. I have a 40-year-old male who underwent a superficial parotidectomy. ठीक है? So he underwent a surgery which is superficial parotidectomy 3 months ago. This period is also important. And presents with a non-specific symptoms not related to parotid gland or the wound, for which he decided to go ahead with the following tests shown in the image. So image में हमारे पास एक test है. Which of the following statement regarding this is false? So the question number 1 is, what test are you looking at? ये जो आप test आप देख रहे हो, the test that you're looking at, this is your starch iodide test. This is what we call it as the starch iodide test. This is what we call it as the starch iodide test. Now in a starch iodide test, you can see that I have applied this component which is here. ये iodine apply किया हुआ है, इसके ऊपर हमने ये white powder that is starch is applied, and then you see there is an area which is getting discolored. ठीक है? So if this discoloration is present, we call it as a starch iodide test positive. This is the iodine solution that we have placed. इसके ऊपर हमने starch का powder लगाया हुआ है. Now the patient is going to sweat. I'm going to ask the patient to eat and this discoloration will be noticed. It's a starch iodide test. तो मोटा मोटा starch iodide test जो है वो किसके लिए करते हैं? For what do we do the starch iodide test? That's your exam question. For what would you like to do the starch iodide test? Now when you come it down to the starch iodide test, it is done in Frey's syndrome. ये जो Frey syndrome है, this Frey syndrome is also referred to as the gustatory sweating. This is referred to as the gustatory sweating. Now when we talk about the Frey syndrome in the component or in context with the gustatory sweating, इसका मतलब क्या है? Let's try to understand. ठीक है? तो सबसे पहले Frey syndrome जो है, it won't appear immediately. It is not an immediate post-operative complication. It takes time. So ये किसका post-operative complication है? It is a post-operative complication. This is a post-operative complication of superficial parotidectomy. It is a post-operative. This is a post-operative complication of superficial parotidectomy. It's an post-operative complication of a superficial parotidectomy. Remember, it will not occur immediately. Immediately का मतलब है normally जो भी आपके post-operative complications होते हैं, we divide them into immediate, then you have the delayed post-operative complication or late post-operative complications that you will see. ठीक है? So immediate वाले में you will have seroma formation, you have hematoma, you have infections, you have facial nerve compressions. All these can be seen as an immediate post-operative. Frey's is a delayed post-operative complication. Now when I say it is a delayed post-operative complication, when we say it's a delayed post-operative complication, that means this is usually going to occur. It arises after 2 to 3 months. This is usually seen after 2 to 3 months. It occurs after 2 to 3 months of surgery. It occurs post-surgery, that is, it takes a minimum 2 to 3 months for this component to arise, right? Now, what is the basic concept behind it? Now, to understand the basic concept, let's say we talk this as a representation of a parasympathetic ganglion. Let's say this is a representation of the tympanic membrane that is present. This is the tympanic membrane that is present across here. And let's say this happens to be the area where the parotid gland is present, and we have done a superficial parotidectomy. That means this part of the parotid gland is removed, right? Just for the sake of orientation. Now, let's understand what is the objective behind it. So, you have the parasympathetic nerve fiber that is going to relay. This is the parasympathetic nerve fiber that is going to relay. It will pierce the tympanic membrane and then it is going to exit. Now, as soon as it exits, it is going to relay onto a ganglion that is present, and this is your otic ganglion, and via the otic ganglion it will relay the parasympathetic nerve fibers to that of the parotid gland. So parotid gland ka jo parasympathetic nerve relay point hai, right, that is via this component. At the same time, you have the sympathetic nerve fibers. Now, this is the sympathetic component, and this sympathetic nerve fibers or the sympathetic supply is going to come across and it is supplying to the parotid gland, right? So, this is your parasympathetic ganglion. ये आपका parasympathetic ganglion है, ये आपका parasympathetic nerve fiber है. This is your tympanic membrane. ये आपका tympanic membrane है. And via this it is going to relay into otic ganglion. This is the otic ganglion, and this happens to be your sympathetic ganglion, right? So this happens to be your sympathetic nerve fibers, and this happens to be your parasympathetic nerve fibers, right? So this is sympathetic and the parasympathetic nerve fibers. Both of them are giving the supply. Both of them is the nerve supply to that of the parotid gland. So parotid gland का जो sympathetic और parasympathetic supply है, that is via these two components. Now when you're doing a superficial parotidectomy while removing the gland, जब आप gland excise कर रहे होते हो, उस time पे there will be some amount of damage. I think this is slightly not visible, so we'll use a different color. Let's say इसको मान लेते हैं कि ये आपका parasympathetic nerve fiber है, and this is supplying to that of the parotid gland. Okay. Now, when you're removing the parotid gland, there could be damage in the parasympathetic and the sympathetic nerve fibers also. Now, it takes 2 to 3 months them to regenerate, और जब वो regenerate होना शुरू होते हैं, when they start to regenerate, there'll be a lot of cross innervations that are going to occur. There will be a lot of cross innervation during regeneration that is going to occur, and in that regenerative cross innervations, you will see the sympathetic nerve fibers and the parasympathetic nerve fibers will cross, or they will cause an abnormal insertions, but at the same time they'll also supply to the skin. So regeneration के time पे sympathetic और parasympathetic nerve fibers cross होने लगे, they try to they cause it superimposing. तो वो एक दूसरे के ऊपर grow करते हैं, they have a common innervation, at the same time together they are supplying to the overlying skin. इसका मतलब क्या है, मोटा मोटा समझा देता हूं कि पहले क्या होता था कि पैरासिम्पैथेटिक बटन दबाओगे तो सिर्फ पैरासिम्पैथेटिक कंपोनेंट वाज गेटिंग एक्टिवेटेड, जब आप सिंपैथेटिक बटन दबाते हो तो सिंपैथेटिक कंपोनेंट वाज गेटिंग एक्टिवेटेड. अब क्या होगा, जब भी आप सिंपैथेटिक का बटन दबाओगे उसके साथ साथ सिंपैथेटिक ड्राइव तो चलेगी, लेकिन क्रॉस इनर्वेशन की वजह से पैरासिम्पैथिक ड्राइव भी स्टार्ट हो जाएगी और टुगेदर दे विल इंप्लीमेंट ऑन द स्किन. तो स्किन पे ना सिंपैथेटिक बटन दबाते पैरासिम्पैथिक एक्टिविटी भी होगी, पैरासिम्पैथिक बटन दबाओगे तो सिंपैथेटिक एक्टिविटी भी होगी. इसी क्रॉस इनर्वेशन को आप फ्रे सिंड्रोम बोलते हो. इज दैट क्लियर? आई बात समझ में? तो ड्यूरिंग द सर्जरी जब आप पैरोटिड ग्लैंड निकाल रहे थे, आपने सिंपैथेटिक और पैरासिम्पैथिक नर्व फाइबर्स को डैमेज किया. जब वो रीजनरेट करना शुरू करते हैं, वो क्रॉस इनर्वेट करते हैं. क्रॉस इनर्वेट करने के बाद वो स्किन को सप्लाई करते हैं, जो ओवरलाइंग स्किन है. अब क्या हुआ, पहले सिंपैथेटिक पैरासिम्पैथिक अलग अलग थे, दे वर सेपरेट. सिंपैथेटिक वाज हैविंग देयर ओन फंक्शन, पैरासिम्पैथिक वाज हैविंग देयर ओन फंक्शन. दे वर नॉट इंटर mingling, or I can say they are not causing any cross referencing. अब क्या होगा, जब भी आप सिंपैथेटिक दबाओगे तो पैरासिम्पैथिक भी एक्टिवेट हो जाएगा, जब भी पैरासिम्पैथिक दबाओगे तो सिंपैथेटिक भी also get activated, and together they will show you the implication on the skin. This is what we call it as Frey's syndrome. तो Frey syndrome जो है, it is a cross innervation पोस्ट पैरोटिडेक्टमी एंड अप्लाइंग और दे सप्लाई, और ये जो इंप्लीकेशन है ना, ये ओवरलाइंग स्किन पे जाके दे आर कॉजिंग दिस सप्लाई ऑन टू द ओवरलाइंग स्किन. अब इससे प्रॉब्लम क्या होगा? नाउ प्रॉब्लम ये होगा कि every time the patient is going to eat, let's say patient is planning to eat, or if there is a basic thought to eat, जब भी पेशेंट या तो खाना खा रहा है या खाने के बारे में अगर सोच भी रहा है, even if he is thinking about food, either he is eating or he is having a thought about eat, what is going to happen? Now this is going to release or cause activation of both sympathetic as well as parasympathetic gateway. But what is going to happen? Every time the sympathetic is going to get activated, it will also stimulate the parasympathetic pathway. Every time the sympathetic, so you have this cross innervation. जब भी आप sympathetic activation होगा, वो parasympathetic भी activate कर देगा. जब भी parasympathetic activation हो, वो sympathetic activity will also cause. And we all know that the sympathetic drive, whenever the sympathetic drive is going to pick up, it will cause increase in blood flow. और ये जो blood flow है वो आप overlying skin पे देखोगे. Now increase in blood flow will result in warmth, and this is what we call it as feeling hot. It will also result in redness, and this is what we call it as erythema. So there will be presence of redness and hot on the area which is getting cross innervated because of sympathetic drive. Parasympathetic is known to cause increased in secretions. It will cause increase in secretions, and here जो secretory component है, that is going to be sweat. So sweat glands gets activated, there will be excessive sweating. Now patient जब भी खाना खाएगा या खाने के बारे में सोचेगा, एक तो ये वाला एरिया गर्म हो जाएगा, लाल हो जाएगा, उसके साथ साथ स्वेट आना शुरू हो जाएगा, and this is also associated with पेन. तो ये दर्द भी होने लगा बिकॉज ऑफ एक्सेसिव सेक्रीशंस. ठीक है, तो क्रॉस इनर्वेशन में पेन भी है, स्वेट भी है, वार्मथ भी है, रेडनेस भी है, एंड दिस ऑल टुगेदर इज व्हाट वी कॉल इट एज द कॉन्सेप्ट ऑफ गस्टेटरी स्वेटिंग. ठीक है, नाउ हाउ डू यू नो अ पेशेंट इज हैविंग योर फ्रे सिंड्रोम? तो फ्रे सिंड्रोम के लिए सबसे इंपॉर्टेंट है दैट हाउ वुड यू लाइक टू डायग्नोस. ठीक है, नाउ रिमेंबर द इन्वेस्टिगेशन ऑफ चॉइस फॉर द फ्रे सिंड्रोम is going to be your starch iodide test. So इसका जो बेसिक कॉन्सेप्ट है कि पहले आप आयोडीन सोल्यूशन लगाओगे, उसके ऊपर स्टार्च पाउडर लगाओगे, एंड आस्क द पेशेंट टू थिंक अबाउट द फूड और आस्क द पेशेंट टू ईट. जैसे ही स्वेट होने लगेगा, स्वेट जो है वो आयोडीन के साथ कंबाइन होगा, एंड देन इट इज गोइंग टू गेट गिविंग यू अ बिट ऑफ ब्राउनिश कलर, दैट इज द डिस्कलरेशन दैट विल बी सीइंग ऑन द स्टार्च एरिया. स्टार्च पाउडर व्हाइट होता है जैसे हमारे इमेज में यहाँ पे है. अगर आप ध्यान से देखोगे, स्टार्च पाउडर व्हाइट है, आयोडीन सोल्यूशन लगाया, स्टार्च पाउडर लगाया, पेशेंट को बोला अभी खा ले, स्वेट कर ले, यू विल सी दैट डिस्कलर्ड एरिया, एंड प्रेजेंस ऑफ डिस्कलरेशन इज पॉजिटिव फॉर योर स्टार्च आयोडाइड टेस्ट. सो स्टार्च आयोडाइड टेस्ट में जो पॉजिटिव रिजल्ट आएगा, पॉजिटिव मीन्स देयर इज प्रेजेंस ऑफ डिस्कलरेशन. ठीक है, अच्छा, व्हेन यू नो ऑल दिस कैन हैपन, तो आपको तो ये पहले भी पता होगा, प्री ऑपरेटिवली पता होगा, सर्जरी करने से पहले भी यू नो दैट दिस इज गोइंग टू हैपन. सो माय क्वेश्चन इज फ्रे सिंड्रोम अ प्रिवेंटेबल कॉम्प्लिकेशन और नॉट? एनीबडी वांट्स टू गिव मी अ फीडबैक? इज फ्रे सिंड्रोम अ प्रिवेंटेबल कॉम्प्लिकेशन और नॉट? यस और नो? इज फ्रे सिंड्रोम अ प्रिवेंटेबल कॉम्प्लिकेशन? हाँ या ना? यस और नो? It is 100% a preventable complication. All that you have to do, देखो ये पूरा प्रॉब्लम ना क्रॉस इनर्वेशन की वजह से आ रहा है. Now if I am able to place a barrier between the skin, if I am able to place a barrier between the skin and the overlying structures, this can very well prevent the cross innervation to the skin. I just want that the skin should not get infiltrated. ठीक है, मेरा ऑब्जेक्टिव क्या है कि मैं ये चाह रहा हूं कि ये जो क्रॉस इनर्वेशन ना स्किन को इनर्वेट ना कर पाए. तो कैसे प्रिवेंट करोगे? सो यू हैव द प्रिवेंटिव मेजर्स. दिस इज ऑल्सो योर एग्जाम क्वेश्चन. हाउ डू यू प्रिवेंट योर फ्रेज सिंड्रोम? नाउ इन ऑर्डर टू प्रिवेंट योर फ्रेज सिंड्रोम, the components that you have. Number one, you can use a muscular flap, that is your sternocleidomastoid muscle flap. आप sternocleidomastoid muscle जो है वो यहां से कट करके ऊपर की तरफ लगा दो, राइट, there's a flap there. So उसके ऊपर आपका स्किन कवर आ गया, तो जो क्रॉस इनर्वेशन होगा वो मसल को होगा, it will not occur to the skin, so hence there will be no symptoms that you can see. So that is your first thing that you can do as a sternocleidomastoid muscle flap. The second thing that you can do is use a temporal flap. Again, all these flaps are basically preventing the cross innervation. And last, you can use an artificial membrane. Now, these artificial membranes will also act as a mechanical barrier and it won't allow the cross innervation to occur. So, you can use the sternocleidomastoid muscle flap, you can use a temporal flap, or you can also use a artificial membrane. ये तो preventive measures हो गया. Now that I know the patient is having a Frey syndrome, how would you like to manage? Now, if I say the first line management, which is also the management or the treatment of choice, now this happens to be the injections of botulinum toxin. These are the injections of botulinum toxin. So where would you give the botulinum toxin? That's a very, very important component that you need to understand. Now, if this is the region where you have the gustatory sweating, now this was the entire area where we have put up a starch iodide. So यहाँ पे हमने starch का powder लगाया हुआ. Now this is the area which we have coated with starch iodide, and then we asked the patient to eat and there was a sweating. Now because of sweating, you know, there was areas of discoloration, and let's say this was the area which is getting discolored. So itna area tha jo discolored, right? Now your objective is to inject the botulinum toxin in the area which is discolored, not the area which is normal. जिस area में discoloration present है, इस area में I will go and inject the botulinum toxin. So botulinum toxin is injected in the area of discoloration. जहां पे discolor हुआ है, wherever the discoloration has occurred, that is the area of injecting your botulinum toxin. So this is the area of discoloration that you have. Because see, when you have discoloration, that means there you have active sweating. Now when you have an active sweating, that active sweating is because of cross innervation. So I have to de-innervate. In order to de-innervate, I have to inject botulinum toxin. So that's the treatment of choice, right? The other things that you can add in these patients, the other thing that you can add is I ask the patient to take an antiperspirant, that is anti-sweating agents. Now, if this fails, you have the second line, which is not very popular. The first line is more than enough. The second line is going to be surgery. And the surgery, remember the name, it is called as the Jacobson's tympanic neurectomy. It is called as the Jacobson's tympanic neurectomy. This is referred to as the Jacobson's tympanic neurectomy. Now, what is this Jacobson's tympanic neurectomy is? I am going to do a preganglionic neurectomy, right? So, what is this Jacobson tympanic neurectomy? You see the parasympathetic ganglion is present here, piercing the tympanic membrane. As soon as it goes out of the tympanic membrane, before going on to the aortic ganglion, if you excise your parasympathetic nerve fibers, this is what we call it as the Jacobson's tympanic neurectomy, JTN. That is your Jacobson's tympanic neurectomy, is to basically compromise the parasympathetic nerve fibers before it relays onto the aortic ganglion. So there is parasympathetic component is taken away. Okay? So this is your Jacobson's tympanic neurectomy. What else can they ask you with respect to the parotid surgery? A couple of important questions that they can ask you if I summarize here. Now, what is the name of the incision for parotid surgeries? So, if they ask you the parotid surgery incision, when you talk about the parotid surgery incision, it is what we call it as the lazy S, or also referred to as the Blair's incision. Also referred to as the Blair's incision or the modified Blair's incision. A lazy S, a modified Blair's incision. The question number 2 is, how do you identify? or what is the landmark to identify your trunk of the facial nerve? ठीक है, so facial nerve identification. So how do you identify the trunk of facial nerve? Intraoperatively. Intraoperative. Now, how do you identify the trunk of the facial nerve intraoperatively? Again, a very, very important question. Now, there are different methods. The first one is what we call it as the Conley's point, or the Conley's pointer, or commonly referred to as the tragal pointer. Commonly referred to as the tragal pointer, which is basically 1 to 1.5 centimeters. It is 1 to 1.5 centimeters deep and medial to the tip of the tragal cartilage. It is 1 to 1.5 centimeters deep as well as medial to the tragal cartilage. That is your Conley's pointer. Another one, it is can be felt on the superior border or the superior border of the posterior belly of the digastric muscle. On the posterior belly of digastric muscle. And another one, when you pierce a hole through the mastoid. When you pierce a hole through the mastoid, you again land up to the trunk of the facial nerve. So Conley's pointer is one which is expected from the exam. Then you have the posterior belly of the digastric and the mastoid component. Okay. Chalo. Now, if you have understood all this basic about the parotid surgery, let's go back to our question. क्वेश्चन सवाल क्या पूछ रहा है? ये बोल रहा है कि 40 years old man है, सुपरफिशियल पैरोटेक्टमी हुई है, 3 months पीरियड हैज बीन पास्ड. हमने अभी डिस्कस किया था कि पोस्ट पैरोटेक्टमी इट शुड बी मिनिमम 2 to 3 months, सो ऑब्वियसली 3 महीने हो गए हैं. टेस्ट गिवन है, स्टार्च आयोडाइड टेस्ट पॉजिटिव है. विच ऑफ द फॉलोइंग स्टेटमेंट रिगार्डिंग द इमेजेस फॉल्स? The statement number 1. What is the statement number 1? The statement number 1 is telling you that this is the investigation of choice. Is it the investigation of choice or not? You will be a better person to tell me. Is this an investigation of choice? The answer is correct. Starch iodide test is the investigation of choice. Option number 2. Injections of botulinum toxin in the white areas and sparing the discolored area is the treatment of choice. This is absolutely wrong. Why? क्योंकि आप botulinum toxin white areas में नहीं दोगे, आप discolored areas में दोगे. यहाँ पे बोल रहा है कि discolored area को spare करना है. Why would I spare it? In fact, I'll give the injections in the discolored area. So this is wrong. Next option that you have, what is the next option? The next option that you have is Jacobson's tympanic neurectomy can be performed. It is correct. Parasympathetic innervation is sacrificed in the surgery for treating this condition. The other options are correct. So these 3 options are correct. So answer here is going to be B for Bombay. It is going to be B for Bombay. Clear है? Clear है? ठीक है? चलो. So, going to question number 2. Again, ये हमारा repeat exam question है. इस पे आप star mark दे दो, चांद डाल लो, कुछ भी डाल दो. Very, very important. ठीक है? Now, you have the cannulas which I've given in the form of color, and then you have the flow rate. You just need to match it. ठीक है? So, if you look at the objective here, this is the green cannula. This happens to be your orange cannula. This happens to be your gray cannula, and this happens to be your pink cannula, right? So based upon the color, you have to match its flow rate, and that's your question. So again, we'll be talking about how do you analyze that. It's a very simple component. Now, so I'll talk about the size of the cannula. We talk about the color code, and then you have the flow rate. Then you have the flow rate, right? Now, when you talk about the cannulas, we have the 14 gauge needle, we have the 16 gauge needle, we have the 18 gauge needle, then you have the 20 gauge needle, then you have 22 gauge, then you have the 24 gauge needle and the 26 gauge needle. These are the standard needles that we have, right? Now when it comes down to the color codes, when it comes down to the color code, 14 gauge happens to be orange colored, 16 is going to be gray, 18 is going to be green, 20 gauge is going to be your pink, 22 is blue, 24 is yellow, and 26 is violet, or it can also be called as purple, right? Now, how much is the flow rate? The initial flow rate that you're looking at for 14 gauge, it is 240 ml per minute, right? Then your gray at 180 ml per minute. The green is going to be half of that, that is 90 ml per minute. Pink is going to be around 60 to 65 ml per minute. So we'll take a smaller number, that is 60 ml per minute. Blue is 35 ml per minute. Yellow is going to be 20 ml per minute, and violet is going to be 12 ml per minute. Going to be 12 ml per minute. So these are the flow rates, color codes, and all these. You need to know the numbers and remember at the same time. Now, easiest way to remember, I have a small mnemonic for all my students. देखिए, द कोर ऑफ द अर्थ इज मेड अप ऑफ लावा. लावा ऑरेंज कलर का होता है. लावा के ऊपर आपको सॉइल मिलेगा. सॉइल जो है वो आपकी ग्रे कलर की होगी. सॉइल के ऊपर यू विल गेट दिस ग्रीन ट्रीज, और इन ग्रीन ट्रीज पे यू हैव दिस ब्यूटिफुल पिंक फ्लावर्स. Above the pink flowers you have the blue sky. This is the blue sky. और sky में you have the yellow sun. And beyond sun you have the universe. मेरे पास violet नहीं है तो I'm using a darker blue color just to be precise. So universe is violet. So this is the universe, and this was happening in the sky. Okay. Now, so this was the universe, and this is the comp. ठीक. Then you have, just for the sake of understanding, इसको मान लो कि stars हैं. अगर आपको नहीं लग रहा कि universe है, just for the sake of it. ठीक है. Now when you look at this, this is your 14 gauge. This happens to be your 16 gauge. This is your 18 gauge. This is your 20 gauge. This is your 22 gauge. This is sun is 24/7, 24 gauge, and this happens to be your 26 gauge, right? So you know the color code, you know the flow rate, all that. अच्छा, easiest way to remember, अगर कभी कोई doubt रहे तो एक छोटा सा easy way to remember. You remember the orange color, you remember the green, and you remember the blue. इन तीनों को याद रख लेना. 240, 90 ml and 35 ml, right? उसके बीच का डेटा अपने आप याद रह जाएगा. That is as simple as that. ठीक. So if you have known all this, this is your question. I'll just write the data also ना, फिर भूल जाओगे. ये क्वेश्चन नंबर 1 का था. ये हमने डिस्कस किया क्वेश्चन नंबर 2 का. ठीक. So this is about question number 2. So you have the color codes and the flow rate. तो यहाँ पे भी मैच कर लो. ग्रीन का क्या था? It is going to be 90 ml. So green is going to be B. Orange का क्या था? Orange was the lava. Lava is beyond that. So it is 240. A हो गया. Gray का क्या है? Gray is above the lava. तो 180 हो गया. C. and pink is going to be 60 to 65, so pink is going to be D. So BACD कहाँ पे है? BACD, B, we have BACD, so answer here becomes A for Ahmedabad. ठीक है, clear है? Clear with the cannulas? Okay. चल, नाउ कैनुलास के बेसिस पे आपसे मैक्सिमम सवाल प्रीवियस एग्जाम्स के क्या पूछ लेगा. नंबर 1, व्हाट इज द मिनिमम साइज ऑफ कैनुला? व्हाट इज द मिनिमम साइज ऑफ कैनुला यूज्ड फॉर ट्रॉमा रिससिटेशन? एंड व्हाट इज द आइडियल साइज ऑफ कैनुला यूज्ड फॉर ट्रॉमा रिससिटेशन? मिनिमम पूछेगा तो बोलना है 18 गेज. आइडियल इज गोइंग टू बी योर 16 गेज नीडल. Ideal it is going to be your 16 gauge needle. If they ask you what is the size of the needle used for FNSE, FNSE में आप कौन सा गेज का needle use करोगे? Remember FNSE में I will use FNSE में I'll be using a 22 to 26 gauge needle. I'll be using between 22 to 26 gauge needle. Now if they ask you for a true cut, what is the needle? I'll be using a 14 gauge needle. For a true cut, I'll be using a 14 gauge needle. So this is the baseline data in terms of needles that you need to know. Now जब कैनुलास की बात आएगी ये तो फ्लूइड्स का भी यहीं पे क्लोज कर लेते हैं. Now question is fluid of choice. Fluid of choice in trauma resuscitation. Then you have fluid of choice. Fluid of choice in burns. फिर पूछ लेंगे fluid of choice in acute pancreatitis. Fluid of choice. Fluid of choice in acute pancreatitis. Fluid of choice in acute pancreatitis. And another component is, if they can ask you, okay, fluid of choice in renal failure in trauma. We have anuria, or let's say as in renal failure, fluid of choice for a patient is having anuria in trauma. Anuria in trauma. Okay. So पहला आंसर क्या होगा? Fluid of choice. Fluid of choice. Fluid of choice in trauma. It is going to be ringer lactate preferred over normal saline. Burns में no doubt it is ringer lactate. Acute pancreatitis also ringer lactate. लेकिन अगर renal failure या anuria है, then I'll give normal saline. ठीक है? I hope everybody knows the reason also. In an anuric state, or when you talk about the renal component is compromised, देखिए, whenever there is hypovolemia, your renin, angiotensin, aldosterone system is going to kick in so that it can compensate for whatever the volume is lost. At the same time, whenever there is shock, in a shock, the patient is already in metabolic acidosis. There are disruptions of cells. The potassium is already releasing excess. Now, if the aldosterone is not secreting or the kidneys are not functioning, they'll not be able to flush the excessive potassium out, which will cause hyperkalemia. So, whenever there's an anuric status, whenever there's anuria, I will not give ringer lactate because that can worsen hyperkalemia. Is that clear? Okay. So these are the important components. This slide is more or less an important component that you have to remember with respect to your cannulas as well as in the component of trauma. Clear? Any question? Quick feedback? If not, we can move on to question number 3. कोई सवाल, कोई शक? So talking about question number 3. देख लेते हैं पहले, उसके बाद इसको dissect कर लेंगे. Alright guys, so question number 3. In question number 3, we have a 76 years old male, chronic bedridden, was admitted to the hospital for pre-existing medical condition. While examining, there is an ulcer over the sacral region which has been there for 6 weeks. What will be your opinion for the following case? ठीक है, तो फर्स्ट ऑफ ऑल डायग्नोसिस क्या बनता है इसका? दिस इज 76-year-old मेल, क्रॉनिक बेड रिडन पेशेंट, सेक्रल रीजन पे ऐसे अल्सर बन गया. इट्स अ क्लासिकल केस ऑफ प्रेशर सोर. नाउ इन दिस आई कैन पॉइंट आउट फ्यू इंपॉर्टेंट थिंग्स. ये जो है, दिस इज व्हाट वी कॉल इट एज स्लफ. दैट्स अ इन्फेक्टिव मटेरियल. ये ब्लैक ब्लैक जो है, इट इज योर नेक्रोसिस. So there is necrosis and there is sloughing, both are present. ठीक है, necrosis भी है, slough भी हो गया. ठीक है, so to understand the basic objective, quickly बात कर लेते हैं pressure ulcers के बारे में और pressure source के बारे में. ठीक है, so talk about question number 3 here. We call it as the pressure sore, or also referred to as the bed sore, or also referred to as the decubitus ulcer. Also referred to as the decubitus ulcer. So the pressure sore, bed sore, and the decubitus ulcer, and the decubitus ulcer. Now, first of all, what is the criteria for developing a pressure sore? Remember, the most important criteria to develop a pressure sore, it is if the pressure exerted over a dependent area, is more than the capillary occlusive pressure. If it is more than that of capillary occlusive pressure, and the capillary occlusive pressure is 30 millimeters of mercury. The capillary occlusive pressure is 30 millimeters of mercury pressure. The capillary occlusive pressure is your 30 millimeters of mercury pressure. So the criteria is very simple. If the pressure exerted over a dependent area is more than that of capillary occlusive pressure, that will result in development of pressure sore. Right? Now, if I give you a question, now this is also an important component. If we say what is the overall most common site for the pressure ulcer? The most common site for pressure ulcer, it is the ischium. If ischium is not there, then it is going to be your greater trochanter. If not, then it is going to be your sacrum. Right? Ischium is the overall most common site. If not, then greater trochanter, then it is going to be sacrum. Right? Now, when you talk about the grades of the pressure ulcer, we will talk about grade and its description. Grade 1, there will be presence of non-blanching erythema. Grade 1 is your non-blanching erythema. Grade 2, there is partial thickness skin loss. There is partial thickness skin loss is noticed. Grade 3, there is full thickness skin loss. There is full thickness skin loss. And grade 4, there is involvement. There is an involvement of underlying structure. There is an involvement of underlying structure. And then there is something called as US. US stands for unstageable. US stands for unstageable. US stands for unstageable. And when we say unstageable, that means if an ulcer is covered with slough, debris, or necrotic material, because the true depth of the ulcer cannot be assessed. I will call it as unstageable ulcer. We'll call this as an unstageable ulcer. Now remember, whenever we talk about the management of the pressure ulcers, it has to be preventable. Prevention is the criteria for your pressure ulcers, right? Now, in order to prevent, whenever a patient is having, or a patient comes to you with a bedridden status, if the patient is having a bedridden status, or if there is a patient who is a chronic wheelchair bound, now in both these, the first thing that we'll advise is your frequent change of position. We'll advise for a frequent change in position. Now that's very important. For a bedridden patient, what is the frequency? And for a wheelchair bound patient, what is the frequency? For a bedridden patient, I will advise for every second hourly. For wheelchair bound, in every 10 minutes, I will ask the patient to lift himself off the chair for 10 seconds. In every 10 minutes, he has to push himself off the chair for 10 seconds and sit back, and that's the best way to prevent it, right? Along with that, we will add water or an air bed. We'll add water or an air bed has to be added, and then proper skin care or an adequate skin care and the skin hygiene, especially in the dependent area, should be taken care of, right? This is the prevention method. If you have grade 1, so the management also depends upon the grades of the ulcer. If you're dealing with grade 1, if you have grade 2, if you have grade 3, if you have grade 4, and if you have unstageable, right? Now for grade 1, we say for grade 1 and grade 2, it is going to be a conservative management. Grade 3, we'll do cleaning and debridement. We'll do cleaning and debridement with regular dressings. Should be done. For grade 4 and unstageable, we will do cleaning and debridement with, rather than doing a regular dressings, I will advise the patient for vac closure, that is vacuum assisted closure, right? So whenever we say vac, I think everybody knows vac is an old term. Now we say the negative pressure wound closure system. We now say it is a negative pressure wound closure system. Remember, the pressure that we exert here is minus 125 millimeters of mercury, and later on it might require plus minus flap cover, right? So this is the total management that you will be looking in terms of your pressure source or the decubitus ulcer, right? Now coming back to our original question, सवाल क्या था? सवाल ये था कि what will be your opinion? So first of all, when you look at this, कौन से grade पे आता है? Is it a grade 1, grade 2, grade 3 or grade 4 or unstageable? As this presence of slough and necrosis, I am not able to assess the true depth of the ulcer. It will become unstageable. For an unstageable, what will you do? The option which is going to be here, it is not stage 4, it is not stage 3, it is not stage 4, it is unstageable. So answer here is going to be D. As simple as that. Clear? Okay. Clear, guys? So this is with respect to question number 3. Okay. So let's talk about question number 4. According to the Southampton wound grading system, this wound will be classified as. So when you look at this wound, what am I seeing? See, I am seeing this presence of erythema. There is presence of edema is also there. along with edema, you see there is presence of necrosis. So there is presence of erythema, there is presence of edema around the wound, and there is a necrotic patch that is present in this particular wound. So let's see what does your Southampton wound grading system is going to talk about it. So we'll take the same component here. We'll talk about question number 4. Question number 4, we'll be talking about surgical site infections. We'll talk about the surgical site infection. Now, in the surgical site infection, we have two components. One, we were talking about Southampton wound grading system. Another one is asepsis wound score. So, one, we have the Southampton wound grading system. We have the Southampton. We have the Southampton wound grading system. We have the Southampton wound grading system. Another one is going to be your asepsis. Your asepsis wound score. Talking about the asepsis wound score. So when you talk about the Southampton wound grading system and the asepsis wound score, दोनों के बीच का जो differentiation criteria वो देख लेते हैं. So let's look across this. In a Southampton wound grading system, on one end we have the grade, on the other hand we have the description. Right. Now here when you talk about grade and description, we have grade 0 where you have a normal healing is noticed. Grade 0 is a normal healing wound. Grade 1, there is presence of minor inflammation. So there is presence of erythema alone. There is presence of erythema alone, that is your grade 1. Grade 2, there will be presence of erythema with other signs of inflammation. With other signs of inflammation. The other signs of inflammation that is noticed, that is grade 2. Then you have grade 3, that is clear or hemoserous discharge is noticed. There could be clear or hemoserous discharge. There is clear or hemoserous discharge is noticed, that is grade 3. Grade 4, there is pus discharge. This is your pus discharge. And grade 5, there is severe wound infection. There is severe wound infection with or without tissue loss. Without tissue loss, that is tissue necrosis, or there is presence of a hematoma. Presence of a hematoma requiring aspiration. If there is a hematoma requiring aspiration, it will be categorized as grade 5. This will be categorized as grade 5. Right? So normal healing is grade 0, erythema is grade 1, erythema with other signs of inflammation is grade 2, serous or hemoserous discharge is grade 3, pus discharge is 4, severe wound infection with or without tissue loss is 5, or there is hematoma that requires aspiration, also will be classified as 5. Now in an asepsis wound score, the asepsis itself, I have written ulta, galat likha hua, asepsis wound score. So the asepsis your asepsis itself is a mnemonic. So when you look at the asepsis criteria, in asepsis, A stands for, does the patient require additional treatment for or requiring additional treatment for wound healing? If there is an additional treatment required for wound healing, additional treatment required for wound healing, that is your asepsis wound score in A. S stands for if there is presence of serous discharge. If there is presence of serous discharge. E stands for presence of erythema. Presence of erythema. P stands for purulent exudate, or there is pus that is coming out. Another S stands for ASEPSIS. Another S stands for separation of deep tissue. If there is separation of deep tissue, that is wound infection is deeper. I stands for cultured organism, that is isolation of organism, and last S is stay in hospital. So if there is isolation of organism, if there is isolation of organism, that says there is an active infection. This, see the ideal form to know whether there is a wound infection or not, that is culture. If culture is positive, you cannot deny it. S is stay in inpatient. Stay in inpatient for more than or equal to 14 days due to wound infection. All these are the parameters that were put into the asepsis wound score. Right. Now, coming to our question, in what category will you look at this? Now, if you look at this particular image, you see along with erythema, this demarcation, you can see normal skin, and this is all that excessive fluid with the blood. So it's presence of hematoma also, right? So this is an extensive hematoma, and this requires aspiration. So there is, I'm not worried about erythema because erythema can be seen in grade 2, grade 3 also. Edema can be seen in grade 3 because we talk about what is grade 3, erythema with other signs of, grade 2 is erythema with other signs of inflammation, right? So grade 0, normal healing, grade 1 is erythema, grade 2 is erythema with other signs of inflammation. So if there is only erythema, it will be grade 1. If there is edema, it will become grade 2. If it is necrosis, it is becoming grade 4, right? If you have hematoma that requires, if you have, I'm saying, okay. What is grade 4, guys? What is grade 4? Grade 4 is pyogenic discharge. Presence of tissue necrosis is grade 5. Hematoma requiring aspiration also becomes grade 5. So when you have multiple components which are pointing towards it, you need to find which is the highest one. And highest among this is going to be our D for Delhi, that is grade 5. It's a grade 5. Sorry? Okay. This is again a very important exam question. Your Southampton wound grading system. Clear? Right. So far, any questions? कोई सवाल, कोई शक, कोई doubt, anything? Quick feedback. So talk about the question number 5. Okay. Now, in question number 5, which of the following statement regarding the image shown is false during the process of creating a pneumoperitoneum for a laparoscopic surgery? Okay. Now, if you look at the image, I have given you the image of a particular device here, and this is what we call it as your Veress needle. This is what we call it as the Veress needle. And you see there is a drop of saline here, and this image is denoting the saline drop test. This is denoting the saline drop test. Okay. Now, let's look at the basics of laparoscopy, and then we'll come back and look at the question. So quickly देख लेते हैं question number 5 में. So talk about the laparoscopy. Now we talk about the laparoscopy. The first thing first. In a laparoscopy, the first thing that you will do, it is to create pneumoperitoneum. Now to create pneumoperitoneum, in order to create pneumoperitoneum, the first thing that you will do is to take an axis. You need to take an axis in order to create a pneumoperitoneum, and the axis is taken by your Veress needle. The axis is taken by your Veress needle, right? Now, when we talk about the Veress needle, a quick component, what is the angle of insertion? तो Veress needle में दो angles पूछ लेगा, angle between the needle and the skin, angle between needle and skin during insertion, and the second question is angle between needle and the body. The two questions that they ask you, what is the angle between the needle and the skin during insertion? Another one, what is the angle between the needle and the body during insertion, right? Remember the first answer, that is needle and skin is going to be 90 degrees, body and needle is going to be 45 degrees, right? This itself is an important point to be remembered. So first thing is to insert the Veress needle. Now third thing they can ask you is, when you are inserting the Veress needle, right, it will be pointing towards the Veress needle while insertion. It is pointed towards which point? So when you are inserting the Veress needle, you will point towards the pelvis, or would you point towards the xiphisternum? So when you're inserting the Veress needle, will you point, when you're inserting, would you like to go towards the xiphisternum, towards the pelvis? The answer, it is always pointed towards the pelvis. Because even if you overshoot, you will land up in bladder. But if you overshoot while pointing towards the xiphisternum, you will go into your pericardial space. So you're going into mediastinum, which is going to be very dreadful. Okay. So the first thing is about Veress needle. Veress needle mein angles important hai, between the needle and the skin, between the needle and the body. Where will you point towards? And how do you confirm the position of the Veress needle? How do you confirm the position of your Veress needle? That means whether, how do you know that is it, or if it is inside, the peritoneum, or is it outside the peritoneum? Now, in order to confirm, you do two things. One, you do a saline drop test. Another one is your saline irrigation test. One, you do a saline drop test and a saline irrigation test. Now, what is a saline drop test is, as you can see in the image that we have given, I'm going to put a drop of saline onto the Veress needle and I lift the abdominal wall. If the drop slides, that is, it is inside the peritoneal cavity. If the drop fails to slide, it is in the abdominal wall only. Okay? So as it goes, you know it is there. What is an irrigation? I'll take the 10 cc syringe attached to the Veress needle. I'll flush the saline. It should go without any resistance. And when I aspirate back, I should get nothing. Right? I should not be able to aspirate back the same fluid, or I should be able to aspirate air, as simple as that. इससे ज़्यादा कुछ नहीं होना चाहिए. ठीक है? इसको बोलते हैं saline irrigation test. So this is about your Veress needle. अच्छा, Once you have put the Veress needle, the second thing, there will be inflow of gas. Second thing that we are going to do, it is to create an inflow of gas to create pneumoperitoneum. Now, in the inflow of gas to create the pneumoperitoneum, the most common gas used to create pneumoperitoneum will be your carbon dioxide. The question that will ask you is, what is the initial flow rate? What is the initial flow rate and what is the maximum flow rate? What is the maximum flow rate that you're going to use? Now remember, the initial flow rate is at 1 to 4 liters per minute. Maximum flow rate I can keep as 20 liters per minute. Now remember, the third thing is to maintain the intra-abdominal pressure. It is to maintain intra-abdominal pressure, and remember the pressure that is expected to be maintained. The pressure that is expected to be maintained is between 12 to 15 millimeters of mercury. No less, no more, right? So this is with respect to Veress needle and how do you create a pneumoperitoneum. The second thing, as an undergraduate you should know, it is about the instrument placement. You have the instrument placement. Now in the instrument placement, you don't need to know much about it. Whatever I'm going to tell you, just remember that. Now if you take this as the representation of the abdomen, you will see you will have one port that will be put. This is what we call it as the camera port, right? So this is the camera port. Now the camera port is also called as the optical axis. This is what we call it as the camera port, or also referred to as the optical axis through which you will put your camera, right? Usually it's a 10 millimeter port. Then you have two separate ports. They are called as the working ports, which you will be using to operate. So we say working port number 1 and we say the working port number 2. We have the working port number 1 and the working port number 2. As simple as W stands for working port. Now the question that they'll ask you is, what are these angles? Now remember, the angle between the optical axis and the working port. The angle between the vertical axis, your optical axis and the working port will be at a 30 degrees. Angle between the two working ports. The angle between the two working ports will be your 60 degrees. The angle between the two working ports will be 60 degrees. And the angle in which, with respect to body that it makes, it is called as an elevating angle, and this angle will also be at 60 degrees. This angle will also be at 60 degrees. So this 60 degrees is what we call it as an elevating angle. The angle between the optical axis, and the working port is what we call it as the azimuth angle. This is referred to as azimuth angle. And the angle between the two working ports, this is what we call it as the manipulating angle. This is what we call it as the manipulating angle, right? So these are the various components that you have to remember. So a lot of other components, you can head down to my lecture on our Meded app also. You will see the entire video lecture for your laparoscopic port placements, how do you analyze your post placement, what are the devices that we're going to use, all the lab instruments, everything is put across there. Okay? So now let's go back to our question. The question says, which of the following is false in these four options that we have? Now, is this the test to confirm the pneumoperitoneum? I am not confirming the pneumoperitoneum. I am only confirming the position of your Veris needle. The angle between the instrument and the skin is 90 degrees. That is correct. This instrument is known as Veris needle. It is correct. It will make 2 click sounds before entering into the abdomen. This is also correct. Now, one is when it pierces the rectus sheath. Another one when it is going to pierce the peritoneum. So, there are 2 click noises that you hear, which is correct. So, other 3 statements are correct. The wrong statement is option A. So, A for Ahmedabad is wrong. Clear? So, false statement is A for Ahmedabad. Clear, guys? So, let's move on to question number 6. Okay, so let's continue. Question number 6. In the question number 6, I have a 55-year-old emaciated, that means emaciation का मतलब है complete weight loss. Okay, patient has become very thinned out. Emaciated alcoholic male presented with a 2-day history of chest pain after a forceful vomiting. ठीक है, forceful vomiting के बाद chest pain, alcoholic, Boerhaave syndrome is what you're looking at. Now he's taken to an OR for a thoracotomy after he is found to have an esophageal rupture, classical case of Boerhaave syndrome. A jejunal feeding tube was placed and he started on tube feeds on POD1. When he develops, confusion is there, shallow breathing is noticed and pulmonary edema has developed. What electrolyte abnormalities do you expect? So this, a patient is already emaciated, that means poor nutritional status, underwent a surgery, he was not fed, and after POD1 we are now started on feeds. So all these problems are occurring after the patient is put on feed, hence the patient is suffering refeeding syndrome. So ये आपसे इतना पूछ रहे हैं कि electrolyte imbalance and refeeding syndrome क्या होता है, ठीक है? So let's understand the basic concept of refeeding syndrome. So question number 6. To talk about question number 6, we're talking about refeeding syndrome. Now, when we talk about the refeeding syndrome, it occurs when a patient is being starved for long duration of time. So when the patient is under starvation, when the patient is in starvation, he will have low sugar intake. When there's low sugar intake, there will be low insulin secretion that is present. Now, this patient who is starving, we will take or we'll suddenly give the patient food. So, he is now been fed. So, when the feeding occurs, when the feeding kicks in, what is going to happen? There will be a sudden surge of sugar. Now, because of the sudden surge of sugar, there will be excessive amount of insulin or there will be over insulin secretion. It is more like hyperstimulus that the patient is getting. Now, what is going to happen if there is an excessive insulin secretion? We all know excessive insulin secretion will activate the sodium potassium ATPase pump, right? It will result in activation of sodium potassium ATPase pump is getting activated. Now, because of that, what is going to happen? Excessive amount of potassium will be pushed back into the cell. So, what will happen? There will be hypokalemia. So, the first electrolyte imbalance that you will see, the potassium is going to go down. Now, at the same time, because insulin is an anabolic hormone, it's an anabolic hormone. It is going to promote anabolic status, and the cofactors required for anabolic status is your magnesium. So, there will be hypomagnesemia, there will be phosphate, there is hypophosphatemia, and thymine, which is B1, which is going to be utilized. So, because of this anabolic status, there is hypomagnesemia, hypophosphatemia, as well as thymine deficiency, and all these put together is what we call it as refeeding syndrome, right? So, they're asking in refeeding syndrome, what is the electrolyte imbalance that you see? We have just learned. Will there be an hypophosphatemia? Yes, there will be hypophosphatemia. Hypokalemia will also occur. Hypomagnesemia will also occur. So, answer is A for Ahmedabad, right? Will there be hyperphosphatemia? No, it is wrong. Hypo is correct. Hypo is correct. Hypernatremia? No. Hyperkalemia? No. Hyperphosphatemia? No. Hypernatremia, no. Hypokalemia can occur, hypophosphatemia can occur. So, we can see the some wrong options in either of B, C, D. Answer A is absolutely correct. A for Ahmedabad, that is your refeeding syndrome, right? Any doubts in refeeding syndrome? Okay, that occurs when a patient is put for prolonged fasting period. Clear? Let's talk about question number 7. Now, question number 7, we have drains and we are talking about match the following. It's an easy one. We'll simply quickly go through it. This first one is your Penrose drain. The second one, this is your pigtail catheter. The third one that you have, it is your T-tube, and this is your silicon corrugated drain. This happens to be your silicon corrugated drain. Okay. Now, if you look at this options, just to match it, Penrose is at this, or this is 1, this is 2, this is 3, and this is 4, right? So, A will become 2, pigtail B will become 1, T-tube C will become 4, and D will become 3. So, 2, 1, 4, 3. You have 2, 1, 4, 3. That is 2, 1, 4, 3. Answer here is B for Bombay. It's going to be B for Bombay. Clear? Clear? So quickly talking about question number 7, that is drains. So when we talk about drains, we divide the drains into 2 categories. We have the open and the closed drains. We have the open drains, and then you have the closed drains. Now, open drains work on a principle of passive drainage. They work on a principle of passive drainage. Closed drains can have 2 components. One that is working on passive drainage, and one that is working on active drainage. Right? Passive is because of dependent status, or that is either it is because of the gravity or there's difference in pressure, that is called capillary gradient differentiation that we have, right? So I can divide the drains into 2 components, one that is going to be your open drain and one that is going to be your closed drain, right? So when I talk about the passive drains, the examples of the passive drains. So passive drains, they drain due to gravity. They drain due to gravity, or also referred to as the dependent position, or because of the dependent position. Now the best examples of this, they are the corrugated drains. It's a corrugated drain, and another is your Penrose drain. It's a Penrose drain. Now when we talk about the closed but passive drainage system, they work or they drain due to that is gravity, or also called as the dependent position, or because of capillary gradient, That is, capillary gradient is nothing but difference in pressure. That is basically because of difference in pressure. The pressure inside is more, outside is less, so it has been pushed out. Now, what are the best examples that I can quote for you? Now, the best examples for the passive drains, number 1 is your urine catheter, that is your Foley's catheter, your nasogastric tube, your intercostal drain, that is your ICD. Another one that you have, it is your Robinson's drain. It's a Robinson's drain. So Foley's, nasogastric tube, your ICD, Robinson's, everything goes in your passive drainage. Now we talk about the active drainage. They drain due to pressure, or they drain due to negative pressure that is applied. They drain due to negative pressure. They drain due to negative pressure. Now the examples that you have for the active drains, Number one is your Romovac drain. Number one is your Romovac drain, and number two is your Jackson-Pratt drain. Jackson-Pratt drain. And Jackson-Pratt, we have already put a lot of posts, you have these videos which are available in our app also. It is there on the Instagram channel also. Recently, we have done a series on drains. You can go look at it. You can find them on my Instagram channel also. That is your, the surgery guy is the channel's name. You can go down there. You'll see all the recent drains with images and their functions have been described there. Okay? So this is all the various drains, their functions, all these are important. Okay? So this is a classification of drains. Now, max to max, they'll ask you, trick you, is your drain removal period. Drain removal period. Now remember, drains are purpose driven. Once the purpose of the drain which is put is finished, you will remove the drain as well. For example, if I put a drain for thyroid surgery, I am basically putting the drain to look for the reactionary hemorrhage which occurs within the first 24 hours. So after 24 hours, or I can say after first day, you can go and remove your thyroid drains. The second, if you have put the drain in the breast surgery, we're talking about surgeries like modified radical mastectomies or mastectomies. I have put the drain to look for seroma, which is a byproduct of inflammation. That will be for until 4 days. So after the 5th post-operative day, or if there is less than 25 ml of drain in 24 hours. This is the criteria to remove the drain in the breast surgeries. For if you are putting the drain for a bowel anastomosis, if you have put the drain for a bowel anastomosis, I want to look for anastomotic leak which occurs in the 5th to 7th post-operative day. So I will keep the drain until there. After that, I will remove the abdominal drain. If you have taken a T-tube is placed when you're doing a CBD exploration and when you're doing a bile duct injury repair, any component, we'll be putting a T-tube. The T-tube should be kept a minimum of 10 to 14 days. So I can remove after 10 to 14 days because I want the tract to get matured, and that takes around 10 to 14 days. So thyroid surgery is after 24 hours. Breast is going to be after 5th day. Bowel anastomosis 5th to 7th day. T-tube is 10 to 14 days. If you have put a drain for an infective collection, you will keep the drain until the infection sustains, as simple as that, until it clears out basically. Okay? So this is with respect to the drains. Clear? So answer here is going to be B for Bombay. Right? Clear? Chalo. So talk about question number 8. Question 8 is a straightforward question. It says daycare surgery is defined as admission and discharge in 24 hours, admission and discharge in 12 hours, admission and discharge within 8 hours, admission and discharge within 6 hours. Any active takers? Daycare surgery? Daycare surgery, A, B, C, D. Remember, it is admission and discharge within 12 hours. 24 hours is called as a day surgery. It's a total day surgery. Take a 1 day surgery. A day care is within 12 hours. You operate in morning 6, you discharge the patient by evening 6. That is called as daycare surgery, right? So daycare surgery is going to be with the admission and discharge within 12 hours. As simple as that, right? Now, which of the following is not a criteria for acute admissions to a burns unit? So we're talking about admission criteria in burns, right? So when we talk about the admission criteria in burns, what are the admission criteria in burns? We'll quickly look through the admission criteria in burns and then we'll talk about it. So question number 9, we're talking about question number 8. The answer is B for Bombay. We're talking about question number 9. Question number 9, we're talking about criteria for admissions. criteria for admission in burns. So we're talking about the criteria for admissions in burns. So with quick important components, on what basis are we going to admit? So is there any update in the guidelines for the admission in burns? Quick feedback, guys. Quick feedback. Anybody? Update. Anything that is added? Achha, tell me what are the most important indications for admission. So we're talking about the admissions or the criteria for admission in the acute burns. सबसे important criteria जो है, the first and the foremost important criteria, which is the, see, whatever update I'm telling you, it is from the ATLS perspective. You can also see in your 28th edition of Bailey, but I'll just quickly summarize. Now, the first important criteria, if there is a suspected airway or inhalational injury, if there is suspected airway or inhalational injury, suspected airway or a inhalational injury, that's your first criteria for admission, because all these inhalational injuries can result in acute laryngeal edema, which will cause acute respiratory distress and patient can die because of suffocation, right? Now, if there is requirement for fluid, so if there is fluid requirement, or I can say if it requires fluid resuscitation, if it requires fluid resuscitation, if that burn requires surgery, if there is significant burn, that is if it is more than or equal to 15% of the total body surface area, or if there is burns to the head, face, feet or perineum. If there is burn to the head, face, feet or perineum, it is considered to be a significant component of burn. Now, patient who is from low socioeconomic status, patient with psychiatric illness, if there is any psychiatric illness, if you are suspecting a non-accidental burn, if burns in extreme age, that is age less than 10 years or age more than that of 50 years, right? Extreme of age is another criteria. If there is electrical or alkali burns, if there is electrical or alkali burns, then these are the components that I would say to be looked upon. So this is a new update in the criteria for admission in the burn. As in say, update में क्या है, दो चीजें हैं. Number one, if there is a significant burn, that means area wise there is one more. Another one is extreme of ages. These are two additional components that are put in the admissions for burns or the criteria for admission. So when you go across here, which is not a criteria, looking for which is not a criteria. No, suspected airway injury, I will admit. Any suspicion of accident, no. If it is a non-accidental injury, I will admit. Why non-accidental? It might be an attempt to kill the person. So basically, you're telling that you're suspecting any foul play. Okay? Psychiatric patients, I will admit. 5 years old, extreme of age, I will admit. So the only patient I will not admit is your B for Bombay. It is going to be B for Bombay. Clear? So your question 9, the answer is B for Bombay. Now, question 10, we have given you a table where we are asking you the cleft lip, cleft palate, and the timing for repair. So we'll talk about the timing of repair in cleft lip and cleft palate. So talk question number 10. So talking about the timing for repair in cleft lip and palate. The cleft lip and the cleft palate. Now, it's very simple. The first thing you will see whether you're talking about a cleft lip or a cleft palate. Talk about cleft lip or a cleft palate. Now, if you're talking about the cleft lip, I will see whether you're looking at a unilateral cleft lip or a bilateral cleft lip. If it is a unilateral cleft lip, the timing for repair is between 5 to 6 months. The age of the baby should be 5 to 6 months. If it is bilateral, a month shorter, that is 4 to 5 months. In the cleft palate, I will see whether it is soft or hard palate. We'll look whether it is a soft palate repair or a hard palate repair. We'll see whether it is, we're talking about a soft palate or a hard palate repair. Now, if it is a soft palate, I will repair at 6 months. If it is a hard palate, between 15 to 18 months is the timing for repair. As simple as that. Okay. Now, based upon the combinations, you will answer that when to repair what, right? Now, so we have a patient, we're talking about unilateral cleft lip. If unilateral cleft lip, at what age am I going to repair? It is 5 to 6 months of age. Bilateral cleft lip, I'll repair at 4 to 5 months. If there is soft palate, I will repair at 6 months. Hard palate will be between 15 to 18 months. Unilateral cleft lip with palate repair. Now, if unilateral cleft lip is there and there is soft palate, then one repair I'll do at 5 to 6 months, and hard palate I'll repair between 15 to 18 months. Single breast I'll take 6 months here. Now, so unilateral cleft lip 5 to 6 months. One operation at 5 to 6 months I will do. So the markings here, it is A, B, C, D, and this becomes 1, 2, 3, 4. Now here unilateral cleft lip I will do obviously at 5 to 6 months. So this is A is 1. A is 1. B 4 to 5 months, bilateral single, B is 4, which is here. C, you are doing 6 months and 15 to 18 months. 2 operations, 6 months, 15 to 18 months. So this is going to be 2 is going to be B. And D क्या बच गया? So talking about C, which is going to be 2. D is going to be 2 surgeries, 5 to 6 months one, and yeah, okay, this one. So 1, 4, 2, 3. So, or you can say 1 is A, 2 is C. So A, C, DB, A, C, DB. Where do you have A, C, DB? 1 is A, 2 is C. Okay. Where is 2C? There's no 2C. Okay, then we have to alter. Wow. C is what? Cleft soft is 6 months, single surgery. Another one is hard is between 15 to 18 months, right? 15 to 18 months. So where we are 6 months is there, 15 to 18 months is there. 5 to 6 months, 15 to 18 months is there, right? Okay. Wait. This is getting a bit trickier. I'll make it simple. यहाँ पे लिखा ही गलत है. I'll just reassign. This is A, this is B, this is C, this is D. This is 1, this is 2, this is 3, this is 4. Unilateral cleft lip जो है, unilateral cleft lip, I will operate at 5 to 6 months. ठीक है. So A 5 to 6 months single surgery कहाँ पे आ गई? ये. So A is going to be 1. There is no doubt. Bilateral cleft lip, I will operate at the age of 4 to 5 months. A single operation. So one operation between 4 to 5 months, it is 4. So we have 1 is going to be A and 4 is going to be B. 4B कहाँ गया? I think the numbering is going to be different. Okay, I have to change here. So I think this is 1, 2, 3, 4. This is A, B, C, D. Now let's see. Unilateral cleft lip, single operation. So 1 is A. Bilateral cleft lip, it is D. 2D again. No? D is going to 2D. Okay. Got it. So you have cleft, soft and hard palate. This is going to be 2 surgeries. One is going to be at 6 months. Another one is going to be at 15 to 18 months. So 4 is C. Okay. So we are done ulta. That's the confusion. Hey Bhagwan. Okay. So C for Calcutta. Clear? Whatever this, there's a small confusion in the table format. But otherwise, ye jo criteria hai, it remains or it holds strong. This is what you have to remember. Clear? I hope I did not confuse you. So cleft lip, unilateral, I'll repair at 5 to 6 months. Bilateral, I'll repair at 4 to 5 months. Soft palate 6 months, hard palate 15 to 18 months. Okay? Clear? Chalo. Going on to the next question. Quick feedback. Can we continue? कोई सवाल यहाँ तक? Any questions? Any feedback? So we're talking about the cold storage time. That is an important component in your transplant. Which of the following? We're looking at the cold storage. So maximum and the optimal one. Question number 11. In question 11, we'll be talking about the organ. We'll talk about the optimum time in hours. Optimum storage time in hours and maximum storage time. And the maximum storage time in hours, right? Now the organs that you have, we'll be talking about kidney, we have liver, we have pancreas, we have small intestine, heart and lung. Now for optimum, it should be less than 18 hours. Liver is less than 12 hours. Pancreas is less than 10 hours. Small intestine is less than 4 hours. Heart is less than 3 hours. Lung is also less than 3 hours. This is your optimum time period. When you talk about the maximum one, the maximum I can keep it for 36 hours kidney. Liver I can keep it for 18 hours. Pancreas also I can keep it for 18 hours. Then I'll keep small intestine for 6. Heart I can keep it for 6 hours. Lungs I can keep it for 8 hours, right? So this is your optimum and the maximum time period. So this table is an important table to remember. And the solution in which you're going to put them is your University of Wisconsin solution. It is the University of Wisconsin solution that you will be keeping them in order to keep across. Okay? It's the University of Wisconsin solution. Now, if you go back to our question. Okay, so we have 36 hours as a maximum storage time. This can only be there for kidney. No other organ has this. So kidney again, okay, this is going to be tricky. So let's say this is 1, 2, 3, 4 and this is your ABCD. Okay, 12 hours of optimum period or less than 12 hours of optimum period is seen for liver. 18 hours of maximum can be there for liver and pancreas. And 3 hours of optimum or under 3 hours, it is for both heart and lung. Right, this is what you have learned. Now let's match it. Kidney 1, undoubtedly it is going to be kidney only. So 1 is going to be A. So 1A, the answer is here only. Okay, so B for Bombay, right? Let's see the other one. The second one, liver. Liver is going to be 12 hours optimum. 2 is B. So this is also there. Pancreas, you have 18 hours of maximum because liver is already taken. So I can say safely C is pancreas. Heart is D. So it's ABCD only in the same sequence. So answer is B for Bombay. Answer here is going to be B for Bombay. Clear? Okay. Now, this question again, it's if they have to give a bouncer, they will give a question like this. Question is, which among the following is the minimally invasive technique for the correction of the following condition? Can you identify what is the condition that is depicted here? क्या condition है ये? Any idea? Quick feedback. Any idea? Quick feedback. I'm looking for an option and answer here. What is the condition that I'm looking at? You can see there is a sternal dip. What is this called as? Any idea? Any idea? This is what we call it as Pectus excavatum. This is what we call it as Pectus excavatum. And in the Pectus excavatum, it is called as a dish-shaped deformity. This is defined as a dish-shaped deformity. This is defined as dish-shaped deformity, right? Now remember, in order to correct this, the only thing you have to do is to push back the sternum, and that procedure is what we call it as the Ravitz's procedure or modified Ravitz. Okay? VATS is your video assisted thoracic procedure. So it's a laparoscopic, I mean, it's a minimal invasive technique. VATS ka full form is video assisted thoracic surgery. Clamshell is a type of thoracic incision. When you have to do a bilateral thoracotomy, you'll put an incision that is called as the clamshell incision. NUS procedure is another variant that you can do across here. Clear? Clear? Chalo. So answer here is going to be A for Ahmedabad, that is Ravitz's procedure. It's a Pectus excavatum. इसका opposite क्या है? Pectus carinatum. Pectus carinatum is pigeon chested. Pectus carinatum is your pigeon chested. Clear? Chalo. Are you guys there? Still holding on? So if you need a break in between, let me know. Otherwise, we'll continue to run so. So question number 13. Which of the following statement regarding the phenomena shown is true? This phenomena. What is this phenomena? This is called as capacitance coupling. This phenomena is what we call it as capacitance coupling. देख लेते हैं question number 13. I'll just add here. Question number 13 is what we call it as the capacitance coupling. Okay. So let's understand what is this capacitance coupling. What is this capacitance coupling? Now to understand the capacitance coupling concept, you need to understand that two things that you have. One is what we call it as port, the other one is the handheld instrument. So we talk about the port, another one is your hand instruments. You have the hand instruments. Now, port are those metallic components which will have a hollow tube, and through these hollow tube, you can insert your instruments into the abdomen. So this gets positioned. So this is how a port would look like. So you put your instruments through the port. And let's say you're talking about a handheld instrument, and let's say this is how a handheld instrument would look like. So talking about this is the instrument. So basically you put your hands inside and this is the instrument that you're going to control. You will notice that the inner part, you will notice the inner part of the port will be lined by an insulating agent, and the outer part of the instrument will also be lined by an insulating agent. So there's an insulating agent that is going to be present both on the port. The insulating agent will be present on port as well as handheld instruments, right? So this is your insulating agent. It is your insulating agent. Now, what is the basic concept of having this insulating agent is, when I insert the handheld instruments into the port, so there is a component which is here. There's a component here. I will be connecting my electrical component, right? So whatever energy source that you're going to give, let's say you're going to cut, coagulate, that energy source will flow through the instruments, and then the energy will be delivered to the tooth of that particular instrument, and you'll be, whatever you touch, you'll be able to burn, you will be able to cut, coagulate, whatever is going to happen. Usually what happens is, whenever you put the instrument in the port, let's say we're talking about this is the port. We're talking about this is the port. Let's say this is the port that we're talking about. And let's say these are your instrumental status. And let's say we have inserted the handheld instrument through the port. So I have inserted my instrument which is going through the port, and I'm working, right? So let's say this is the instrument which we are controlling from outside. Let's say these are the instruments that we are controlling from outside, and the electrical component is attached to it. Okay. Now we know there are insulating agent which is present inside the port, and there is an insulating agent which is present on the outer surface of the instrument as well. There is an insulating agent which is present on the outer surface of the instrument as well. Now why this is important is, when you are pushing this electrical component, this electrical impulse is flowing through, it is flowing through the instrument, and then it is touching the tissue. As you can see, the electric component which is present, the electricity can never spray out because of insulating agent. It won't allow the electrical component to go to the port. The reason is, the port can come in contact with the bowel. Let's say this is the bowel that is present. The port or any internal organ, the port can be in contact, but that organ will not get damaged because of intact insulation. Now, in few devices or few instruments, for especially the old ones where there's a lot of wear and tear, now because of wear and tear, you will see there will be loss of insulation in few areas. Now if there's a loss of insulation, what is going to happen? The electrical impulses that are generated will now be able to go out, but here it will not go because the insulation is still there. But area where both of them do not have insulation, what will happen? This electrical impulse will go from there, it is going to go and cause damage in the surrounding organs, right? Now damaging the surrounding organs due to the flow of electrical impulses because of loss of insulation is what we call it as capacitance coupling. It is what we call as capacitance coupling. This is a very simple concept that you need to understand. Now coming back to our original question, what does the question tells you? Now this can be prevented by placing a plastic cuff over a metallic port at the port site. Now, if you only put the plastic at the entry point is not the problem. It is the insulation loss in throughout the tube. So this is going to be useless, right? This cannot be prevented. This is a common with brand new. No, this is common with old instruments. This phenomenon is called as capacitance coupling. True. Dithermy hook current can never flow if the insulation is intact. It can still flow, but the point is it gets very less dissipation. So hence it is not going to cause any component, right? So dithermy hook current can flow, but it will not cause any injury, because if there's an intact insulation, it is going to get earthed off, right? The best way to prevent a capacitance coupling is to use a plastic port, and that is why now you've seen a lot of fiber ports have started to come in, because they prevent capacitance coupling. That's a simple concept that you remember. So answer here is going to be your C for Calcutta. So question number 13, it is going to be C for Calcutta. Clear? It's a capacitance coupling, right? The point D is important. The dithermy hook. This is your dithermy. This is the hook of the dithermy. Dithermy hook current can never flow. It is wrong. It can flow even if the insulation is intact, but it does not cause damage, because the energy which it is going to go out is going to be very, very less. Clear? So that's in your question number 13. Now, question number 14. Now, question number 14, the maximum gain in length is at what angle in the procedure shown? Now, this procedure is what we call it as Z plus T. Now, the Z plus T is done to increase the length of wound contracture. It is to increase the length of the wound contracture. Right? It is to increase the length of the wound contracture, right? So, in simple concept, if I simply tell you, let's say this is the upper limb of the patient, just for the sake of discussion. Now, let's say there is a wound contracture that is developed here. Now, because of the wound contracture, let's say there's a post-burn wound contracture, patient is not able to extend the arm. So, what I'm going to do is, this wound I will take as a referral point, and then I will do a Z plus T. Now, when I do a Z plus T, it will cause elongation. Now, it depends upon the angle, and that angle is this. How much is the angle? There will be elongation for 30 degrees. So, you have 30 degrees, 45 degrees, 60 degrees, 90 degrees that is going to be present. Remember the length that you gain. Now, it varies. For 90 degrees, you have 100% gain. For 60 degrees, there is 75% gain. For 45, there is 50% gain. And for 30, there is 25% increase in length, right? So, the gain in length depends upon the angle. Remember, there is 100% gain in angle 90 degrees. That is, so more the angle, more the gain. But the problem is, as the angle increases, the corner becomes more steeper, and if the corner becomes more steeper, the blood supply will become even lesser. So that Z plus T wound healing will become poorer. So ideal angle, if they say what is the ideal angle? The ideal angle for Z plus T is going to be 75 degrees, but the maximum gain in length is seen at 190 degrees. Okay? So that is with respect to Z plus T. So answer for 14 is going to be D for Delhi. It is going to be D for Delhi. Clear? Sure. So that's your question number 14. Let's talk about question number 15. Now in question number 15, I have a 57-year-old male who had an atrial fibrillation. Okay. Notice to have a platelet drop of 60,000 7 days after initiating of heparin. He does not, okay, he goes on to develop a lower extremity swelling and the pressure of a new DVT, and the presence of new DVT is confirmed with an ultrasound. What, if any, changes should be made to address the anticoagulation regime of thrombocytopenia? So basically, he started to develop thrombocytopenia. There's drop in platelets. He had an AFib, we are giving an antiplatelet, so we are giving basically a blood thinner, and that happens after giving a blood thinner, there's a drop in platelet. Okay? So heparin, after giving heparin, there's drop in platelet, so hence it is called as HIT syndrome. right? So talk about question number 15. Question number 15, we call it as the HIT syndrome. We talk about the HIT syndrome. The HIT syndrome is heparin-induced thrombocytopenia. It is your heparin-induced thrombocytopenia. It is your heparin-induced thrombocytopenia. Now, basically, it's an heparin sensitivity. HIT syndrome is a heparin sensitivity. It is a heparin sensitivity. So as soon as you start heparin, you see the platelet will start dropping. Now in an heparin sensitivity, there will be decrease in platelets. The patient will have bleeding manifestations as well. There will be bleeding manifestations. So in that there's petechia, purpura, bleeding from gums, all is noticed. So the minute you suspect a patient is having an heparin sensitivity, the minute you suspect the patient is having a heparin sensitivity, the first thing you have to do it is to stop heparin immediately. The first thing you have to do it is to stop heparin immediately. But the problem is you cannot stop anticoagulation because this patient is developing DVT on the contralateral limb. So I have to switch. So when you stop heparin, you have to switch to the novel anticoagulant or newer drugs. What are the newer drugs that you can switch to? Number one, you can switch to fondaparinux. We can switch to rivaroxaban. We can switch to apixaban. We can switch to bivalirudin. So these are the options that we have. So fondaparinux, rivaroxaban, apixaban and bivalirudin. Your fondaparinux, rivaroxaban, apixaban is factor 10A inhibitors. Bivalirudin is your direct thrombin inhibitor. DTI, that is your direct thrombin inhibitor, right? So you have to stop and switch to all these anticoagulant, that is for HIT syndrome. Now, other special scenarios that you can talk about it. If a patient is having DVT with contraindication for anticoagulation, examples like recent history of stroke, right? So one of the common things that you will see here is associated with recent history of stroke. If there is recent history of stroke, what will you do? I will install an IVC filter. I will install an IVC filter which is also called as the green field filter, also referred to as the green field filter, right? So these are the two components that you remember. Coming back to our original question, question number 15. Now, continue heparin is not an option, is wrong. Discontinue all anticoagulants and place an IVC filter. I will put an IVC filter if there's a contraindication for anticoagulation. Here it is not a contraindication. Start the patient on bivalirudin. This can be done. Start a platelet transfusion. No, only if there is a bleeding manifestation. So here, C for Calcutta, I will put the patient on bivalirudin. That is a direct thrombin inhibitor because that is the most sensible thing to do in a patient of heparin sensitivity, right? So these are the components to be remembered with respect to HIT syndrome. Clear, guys? Sure. So we'll go to question number 16. In question number 16, which of the following patients with triple, that is abdominal aortic aneurysm, can be medically managed at this point? Okay, so we'll talk about the management protocol for the abdominal aortic aneurysms. So talk about question 16. Question 16, we talk about the management of abdominal aortic aneurysm. We'll talk about the management of the abdominal aortic aneurysm. Now, when you talk about the abdominal aortic aneurysm, now in the abdominal aortic aneurysm, the first thing you have to see whether it is symptomatic or asymptomatic. Whether the patient is presented to you with symptoms, whether it is symptomatic abdominal aortic aneurysm, or is it incidentally found asymptomatic, or whether it is asymptomatic abdominal aortic aneurysm. Now, if it is a symptomatic abdominal aortic aneurysm, the criteria says always repair. It is always repair. If it is an asymptomatic abdominal aortic aneurysm, I would like to measure the critical diameter. So, say the critical diameter of sac assessment. We'll do a critical diameter of the sac assessment. Now, I can get two differentiating data from here. Either the diameter of the sac, either the sac's diameter is less than the critical diameter, either the sac's diameter is less than the critical diameter. On the other hand, the sac's diameter is more than that of critical diameter. I have two components. Either you can have more diameter or lesser diameter, right? If the sac diameter is less than that of critical diameter, then it says observation. It says observation. Now, if it is more than that of critical diameter, then we have to plan for repair. Now, when we talk about the critical diameters, now this is important. Now, critical diameter for the ascending thoracic aorta aneurysm, critical diameter for descending thoracic aorta aneurysm, and the abdominal aortic aneurysm. This is at 5.5 centimeters. This is at 6 centimeters, and this is again at 5.5 centimeters. Now, if a patient is having a Marfan syndrome, patient with Marfan syndrome, if the patient is having a Marfan's syndrome, now in the Marfan syndrome, it is 4.5 centimeter. In Marfan's, it is 4.5 centimeter is the critical diameter. Marfan's 4.5 centimeter will be considered as a critical diameter. Okay. Now, in the observation and follow-up, we are talking about specifically for abdominal aortic aneurysm. We're talking about the abdominal aortic aneurysm. We will see whether it is less than 4.5 centimeters or more than 4.5. See, if it is more than 5.5, then it is repair. But we're talking about 4.5 as the lower limits, right? Now, if it is less than 4.5, I'll ask the patient to come back after 1 year for follow-up. If it is more than 4.5, I'll ask the patient to come back after 6 months for follow-up. Now, after 1 year of follow-up, I will see the increase in size. Increase in the size of sac diameter. Same thing I will be assessing here. I will be seeing increase in the size of sac diameter. Now, I can have two things. There is no increase or there is presence of increase. Here also there is no increase, there is presence of increase. If there is no increase, continue observation. Continue observation and follow-up. Here also no increase, we have to go with observation and follow up. We have to take up observation and follow up, right? On the other hand, if there is increase in size, you have to analyze how much is the increase. Is the increase less than 10 millimeters or has the increase been more than 10 millimeters in a year? If the increase is less than 10 millimeters, observation and follow-up. If the increase is more than 10 millimeters, then you have to go ahead with repair. The same thing will be done here. If the increase is present, we will see if the increase is less than 5 millimeters or more than that of 5 millimeters. If it is less than 5 millimeters, continue here. If it is more than 5 millimeters, take the patient for repair. Okay. So this is the entire algorithm if you're looking at abdominal aortic aneurysms management. Okay. You cannot get a better flowchart than this. Any question on the abdominal aortic aneurysm repairs can be addressed without any fail. So let's go back to our question number 16. Now, which of the following can be medically managed? Now, I have a 75-year-old male with 6.3 centimeter abdominal aortic aneurysm. I cannot manage it conservatively. Critical diameter is 5.5. It is more than that. 68-year-old female with abdominal aortic aneurysm has grown from 4.9 to 5.3 in last 1 year. So here in this option B, the increase has been how much? 0.4. No, 4.9 to 5.3 is 0.4 millimeters increase, or I can say not 0.4 centimeters. No? So it is 4 millimeter increase is that. There's a 4 millimeter increase. A 72-year-old male with a 4.8 and intractable pain. Now pain is present, so this is symptomatic. Again, in symptomatic aneurysms, I cannot manage it conservatively, right? So this I cannot know. A 70-year-old male with abdominal aortic aneurysm that has gone from 4.8 to 5.1 in last year. So here it's a male, it is there. If you look at the increase, 4.8, 4.9, 5, 5.1. So there's an increase in 3 millimeters, right? Now, there's a small component that you need to understand in males and females. In males, the critical increase is 10 millimeters. In females, the critical increase is at 5 millimeters. Okay? Now, which of the following patients can be managed medically at this point, right? Now, in females, because the increase, it's if a 4.9, 5, 5.1, 5.2, 5.3. So it is, okay. I can manage B and D both conservatively, but given a choice, because the critical value is more closer in females and it is 5.3 centimeters. No, so 5.5 is your critical diameter. So it is more closer. So I would not like to manage your B conservatively. D can be managed conservatively. So among given options, D is a better option, right? So 16, D will be a better option. I repeat again. मेल्स और फीमेल्स में ना थोड़ा 0.5 मिलीमीटर्स का फर्क है क्रिटिकल डायमीटर में. 5.5 is what we take in males, whereas 5 is what we take in females. ये थोड़ा सा ट्रिकी पॉइंट है. I don't expect them to, but again logically देखोगे B और D में से ना अगर 5.5 ही मान के चलोगे कि क्रिटिकल डायमीटर, क्लोजर टू क्रिटिकल डायमीटर इज योर फीमेल, दैट इज 5.3 ना, B वाला ऑप्शन. D 5.1 में, it is still far, no, and it is only 3 millimeters increase in a year, so you can wait. ठीक है. So the one that can be managed conservatively is your D for Delhi. ठीक. चलो. Now question number 17. What is this? This is your harmonic scalpel. Now, which of the following statement regarding the following device shown is true? Achha. Now let's analyze the statement. The instrument that uses the ultrasonic technology to cut the tissue without sealing them. See, harmonic scalpels, no, it has the ability to both cut and seal. It can cut and seal. It vibrates at 2000 to 5000. No, it vibrates between 20,000 to 50,000 hertz. So this is also wrong. The tissue protein denaturation caused by vibration rather than heat. Now, a very important component to remember that it is actually vibrating energy that is causing the disruption rather than the heat per se. So this is true. It can seal, divide arteries and veins up to 0.7 millimeters in diameter. It can only do until 0.5 millimeters in diameter. So D is also wrong. So answer for 17 is going to be C for Calcutta. It is going to be C for Calcutta, right? Now remember, harmonic scalpel uses ultrasonic energy, that is vibrating energy, and this vibrating energy causes protein denaturation. It is the vibrating energy that causes the protein denaturation. So it is going to cut and seal. It vibrates at 20 to 50,000 hertz. It is going to use the vibrating energy. It is safe in patients with pacemaker. It is safe in patients with pacemaker, right? So answer here is going to be C for Calcutta. It is going to be C for Calcutta. Clear? Sure. Question number 18. What do you have? What is the absolute contraindication for the device shown in the image? Now this is your capsule endoscopy, right? The device that we have shown you here, it is your capsule endoscopy. Now remember a simple common sense. The only contraindication for a capsule endoscopy is if I'm not able to retrieve the capsule. As simple as that. If I fail to retrieve it, I have to operate and remove it. No, in those places I will not do capsule endoscopy. Simple concept. A tubercular stricture that is going to be present in terminal ileum and a stricture won't allow the capsule to pass, I will not be doing it. For gastric paresis, I can do it. For ileosis, because it will resolve. See, gastric paresis, ileus are also a contraindication. All four are contraindications. But if you look at this, remember these three are relative contraindication, whereas option A is your absolute contraindication. This is your absolute contraindication. So answer here is A for Ahmedabad. 18 is A for Ahmedabad. Okay? Sure. Now, question number 19. What is the characteristic of mesh for hernioplasty? Now, when you talk about the ideal characteristic of the mesh in hernioplasty, number one, it should be hydrophobic. It should repel water. Number two, it should be non-absorbable. It should be non-absorbable. It should be non-absorbable. It should be lightweight. Now, when I say lightweight, it is basically the criteria of being lightweight is less than 40 grams per meter square. It should have large pores, that is micropores, so that tissue gets integrated. Hydrophobic, non-absorbable, light-weighted, and it should have large pores, and these are the characteristics for the mesh in hernioplasty. So lightweight, large pore, that is C for Calcutta. That will be your answer. That is your question number 19. Now, question number 20. How do you calculate the energy that has to be obtained from TPN? Any idea, guys? How do you calculate the energy that you want to obtain from a TPN? Any feedbacks? Quick component. Okay. So we'll go with the nutrition wala. Kahan gaya tha hamara refeeding wala. So when you talk about the TPN, I'll add TPN here only. So this is our question number. How much is the question number? Question number 20. So TPN is your total parental nutrition. So when you talk about the TPN, basic composition is important. Now in the composition of the TPN, the maximum is going to be your carbohydrate. The maximum is your carbohydrate. Then you have fat, which is also referred to as lipid. Then you have proteins. You have vitamins. And you have trace elements. Now, carbohydrate by quantity, it will be at 40 to 50%. Lipids are going to be, or fat is going to be 30 to 40%. Proteins are going to be 10 to 20%, and these are negligible. Vitamins and trace elements are going to be in a negligible state. How much energy will you expect? Remember, from a carbohydrate, it is going to be 3.5 kilocalories per gram. Whereas fats will give you 9 kilocalories per gram, and protein will give you 4 kilocalories per gram. Give 4 kilocalories per gram. Okay. Now, if you apply this to our question, that is question number 16. Sorry, question number 20. So we have sugar 100 grams, amino acids, which is protein 30, and then you have lipid fat. So 40 milligrams of fat, that is going to be 9 kilocalories per gram. So it is going to be 360 kilocalories. 30 of proteins, right? Proteins is going to be 4 kilocalories, that is 120. And then you have 100 grams of carbohydrate, that is 3.5, which is going to be 350. So how much will it be? So 3 zeros are here. 5, 6, 8. 8 plus 5 is going to be how much? 8 plus 5, 30. So 830 is what you're getting, right? 830 kilocalories. Now, among all this, what is closest one is your 840, which is present here, right? So 20 is going to be A. That's it, 830. Clear? So this is how you will calculate the energy that is there in terms of TPN. Now, let's continue. Question number 21. In question number 21, we have, which of the following is not an indication okay. Which of the following is not an indication for surgical intervention in an asymptomatic primary hyperparathyroidism? Now, this is something that's an expected exam question that I expect you to remember, right? Chalo. So, talk about the indications for surgery in an asymptomatic hyperparathyroidism. This is your question number 21. So, talking about indication for surgery. Talking about indication for surgery in asymptomatic primary hyperparathyroidism. In an asymptomatic primary hyperparathyroidism. Right. Now, I have criteria. Number 1, I'll be measuring at serum calcium. We have the skeletal criteria. we have the renal criteria, and the age related criteria. There are 4 components that I will look at. Now, if the patient is age less than, if the age is less than 50 years, asymptomatic primary hyperparathyroidism should be addressed with surgery. Usually it is because of parathyroid adenoma, right? Now, in serum calcium levels, if there is increase in serum calcium by either 0.25 millimoles per liter, or if there is increase by 1 milligram per deciliter over the upper limit, right? This is an indication. What is the basic meaning behind this is, normal calcium is 9 to 11 milligram percent. If it is more than or equal to 12 milligram percent, it is an indication for surgery. ठीक है, normal क्या 9 to 11 है, उसके ऊपर 1 milligram per deciliter, that is 1 milligram percent over the upper limit is 11 and above that is 12. ठीक है, more than or equal to 12 milligram percent. In skeletal, I will do something called as the bone mineral density. I will measure something called as BMD, which is called as the bone mineral density by DEXA scan. I'll do a DEXA scan. I'll measure something called as T score. And remember, if the T score is at minus 2.5 at lumbar spine, minus 2.5 at lumbar spine, at hip, at femoral neck, and distal 1/3 of radius. And distal 1/3 of radius. If anywhere, if you find the T score to be less than it is equal to at a value of minus 2.5, it is an indication for surgery. In renal parameters, I will see 2 important components. One, we will look at creatinine clearance, which is called a CC. We'll look at the creatinine clearance. Now, if the creatinine clearance is less than 60 ml per minute, or if the 24 hours urinary calcium, if the 24 hours urinary calcium is more than 10 millimoles per deciliter, or if there is increased risk for stone formation, right? If these are present, these are the indications for surgery in a patient who is having an asymptomatic presentation of primary hyperparathyroidism. So if you go back to our original question, serum calcium of 1 milligram per deciliter above the upper limit is correct. Age should be less than 50, not more than 50. So this is wrong. Vertebral fractures, all pathological fractures is an indication. 24-hour urinary calcium, if it is more than 10 millimoles per liter, is correct. So answer here is going to be B for Bombay. So age less than 50 is an indication for surgery, not more than 50 is an indication for surgery. So 21 is going to be B for Bombay. 21 is B for Bombay. Clear? So question number 22. In question number 22, we have a 44-year-old G3P2 female whose mother was diagnosed with breast cancer at the age of 65, comes to see in clinic after being told her most recent screening mammogram is BIRADS 3, probably benign. How should you counsel her? See, we have a patient who is a first degree relative is having a breast cancer. No doubt she is at a risk of developing breast cancer. But when you look at the BIRADS 3, he's asking, according to BIRADS, what will you do? If there's a BIRAD 3 which is probably benign, you have to tell the patient there's nothing much to worry about it. You need to put up on follow-up. So rather than having all these assumptions, let's talk about BIRADS first. So talk about the BIRADS assessment. So that's a question number 22. So question number 22, we'll be talking about BIRADS. Now your BIRADS is your breast imaging reporting and data system. It is your breast imaging reporting and data system. It is a breast imaging reporting and data system. That's your BI-RADS, right? Now, according to BI-RADS, we look at the criteria. You have category, description, and management. So we have category 0, which is an incomplete assessment. Now, incomplete assessment where a patient has gone for a, let's say lesion was present on left side and she got ultrasound for the right side. So there's a wrong breast imaging, poor quality of imaging, all this is there. For them, what will you do? You'll ask the patient for repeat imaging. You'll ask for repeat imaging. Category 1, it is negative. Negative for growth. That means there is no lesion, nothing. So I'll ask the patient to continue her annual screening. So continue annual screening. So there is no problem in category. So all patients of your breast screening program for breast cancers, they should always get a category 1 where there's negative for growth. Ask the patient to come back after come back next year for the same component. Now category 2, it is benign. Benign, you don't need to do anything. Continue the patient on annual screening. I am not going to put the patient for anything further, right? Do not do any intervention. So basically no active intervention. So annual screening or no active intervention is required. Annual screening if it is more than 40 years. If less than 40, no active intervention. There is no active intervention if the patient is less than 40 years. Category 3, it is probably benign. For a probably benign, I'll ask the patient to come back for follow-up, but this is your exam question because the follow-up is after 6 months, not after 1 year, as we do it for rest of the other components. Category 4, it is suspicious. It is suspicious of malignancy. Category 5, it is highly suggestive. It is highly suggestive of malignancy. And category 6, it is biopsy proven malignancy. It's a biopsy proven malignancy. For the first two, that is your suspicious and highly suggestive of malignancy, I will advise for a true cut biopsy. For a biopsy proven malignancy, I will advise for stage wise management. I will advise for stage wise management. Clear? So answer here, we have category 3, which is probably benign. So I'll ask the patient to come back for follow-up after 6 months. So ask her to come back for follow-up after 6 months. So here it is B for Bombay. It is going to be B for Bombay. Clear? Sure. Look at question number 23. What do you have in question number 23? I have a 83-year-old thin woman with no history of abdominal surgeries. Symptoms of a small bowel obstruction. On physical examination, she has pain with medial and internal rotation of the thigh. Classical called as Hauschilp-Romberg sign. There is no palpable hernia in the groin. What is the most likely hernia? The answer is your obturator hernia. Now, in an obturator hernia, it originates or the hernia arises through the obturator foramen. When you do the component, that is when you do a knee flexion and then you do an internal rotation of the thigh, you will compress the obturator nerve and that compression will cause shooting pain along the same path of the obturator nerve. And this is what we call it as the Hauschilp-Romberg sign. This is what we called as Hauschilp-Romberg sign. Very component for your obturator hernia. The obturator hernia, it is also referred to as the little old lady's hernia. also referred to as the little old lady's hernia. The management here can be done as transabdominal pre-peritoneal repair or total extraperitoneal repair. Right? It arises through the obturator foramen. This is the obturator hernia. So answer here is D for Delhi. Now, which among the following is concerned or considered as stage 1 of damage control surgery? Right? Now, when you talk about the damage control surgery, we'll quickly look at the stages of the damage control surgery. So, question number 24. So, go with damage control surgery. We talk about the damage control surgery. Now, the confusion arises if they're asking you stage or phase. So, damage control surgery is divided into two components. One is the stage, another one is the phase. Now, in the damage control surgery, stage 1 is your patient selection. Stage 2, it is your primary exploration. Stage 3, it is your ICU care. Stage 4, it is your re-exploration. Stage 4 is your re-exploration. And last one, stage 5, it is your definitive abdominal closure. Right? This is in terms of stage. So when I say what are the phases of damage control surgery, we have phase 0. In the phase 0, it is what we call it as patient selection, which is done in ER. So we do it in the emergency room. That is phase 0. Then you have phase 1. Now in the phase 1, I'll take the patient for primary exploration or exploratory laparotomy. We do exploratory laparotomy. Then we go to phase 2. Phase 2 is your ICU care. Then you have phase 3, which is re-exploration. Your re-exploration followed by abdominal closure. So the only thing which is confusing is almost stages and phases are same. But phase starts from 0 and there is only 0, 1, 2, 3, whereas here there are 5 components, right? Stage 1 patient selection, 2 is primary exploration, 2 ICU, 3 is ICU care, 4 is re-exploration, 5 is definitive abdominal closure. Phase 0 is patient selection, phase 1 is exploratory laparotomy, phase 2 is ICU care, and phase 3 it is going to be re-exploration with abdominal closure. Okay? So here in the question they are asking what is stage 1? Stage 1, it is patient selection. So C for Calcutta. It's just C for Calcutta. Now, question number 25. A 20 months old baby presented with traumatic injury to the spleen, unstable vitals, not responding to resuscitation, planned for emergency splenectomy. Which of the following vaccine is not recommended in this setting? So, post-splenectomy vaccination is again an important concept or a topic that you need to know. So, question number 25, I'll take it here. So, talking about post-splenectomy vaccination. We're talking about post-splenectomy vaccination. Now, we're talking about elective splenectomy. Talk about the elective splenectomy and emergency splenectomy. the elective splenectomy and the emergency splenectomy. In the elective splenectomy, it should be done 2 weeks prior to surgery. And the vaccines that you give, pneumococcal, meningococcal, pneumococcal, meningococcal, and H influenza B. 3 vaccines, 2 weeks prior to surgery. In emergency splenectomy, 1 we have to give immediate post-op and in 2 weeks period of time. We give immediate post-operative vaccination and in 2 weeks period. Right. Immediate post-operative, we will give pneumococcal. But provided you need to know what variant of pneumococcal vaccine you are going to give. So the variation that comes is with respect to age. So less than 2 years or more than 2 years. Less than 2 years, we give P7 valent. More than 2 years, PPV 23, that is 23 valency will give, right? In a 2 weeks period time, you will give the rest of the vaccine, that is your meningococcal and H influenza. Give meningococcal and H influenza B. Right. So this is the post-splenectomy vaccination that you should be aware of, right? So coming back to our original question, which vaccine is not recommended? Now see, here it is 20 months, that means less than 2 years. In less than 2 years, I will not give PPV 23, I will give PPV 7. So it is not there. H influenza, meningococcal, all vaccines are recommended, that is all pneumococcal, H influenza, meningococcal, but PPV 23 will not be given. I will give you PPV 7. The answer here is A for Ahmedabad. Clear? So answer is A for Ahmedabad. Clear? Sure. So we'll take a short break here for 15-20 minutes and we'll resume back. Okay, take a break here, 15 minutes and we'll resume back. Now the management, which of the following is true regarding the following components? Regarding the fluid resuscitation and the urine output. Okay. So let's look at question number 26. According to ATLS, no? Okay. We're talking about burn fluid resuscitation. Now earlier we used to use a formula for a burn fluid resuscitation and that was considered to be as a Parkland formula, right? Now the Parkland formula is now considered to be obsolete, which was actually 4 ml per kg per percentage of total body surface area burnt. Now remember, Parkland is obsolete, we are not using it any longer. So now what we follow is the ATLS protocol. ATLS, we say whether it's a second or a third degree burn, whether it is child that is age less than 14 years or age more than 14 years, right? Now if it is a child, then it is 3 ml per kg per percentage of total body surface area burnt. If it is an adult, it is 2 ml per kg per percentage of total body surface area burnt, right? If it is a 4th degree burn or an electrical burn, irrespective of the age, it has to be 4 ml per kg per percentage of total body surface area that is burned. Now one of the important things with respect to the electrical burns, you will monitor the urine until the urine clears out. until clear urine is seen, right? So you have to monitor until the clear urine is noticed. Now coming back to our question number 26. Now, which are the following regarding the management? True regarding, okay. We're talking about 13 years old, electrical burn. Age does not matter in electrical burn. It has to be a 4 ml. So it can't be 2 ml. So these are wrong. Of ringer lactate. Okay. Okay, 4 ml per kg per percent total body surface area. Ringer lactate is given for 24 hours. 1 to 1.5 ml per kg per hour of urine output. That's one option. Another one, that till urine clear out. This is what I'm looking at. If this is there in the option in electrical burns, I will always prefer B for Bombay. So answer here is going to be B for Bombay. It is going to be B for Bombay. Clear? Now, question number 27. We have the DCD donors, which are called as the dead cadaveric donor, or the donor after cadaveric death or circulatory death. DCD is your donor after circulatory death. So, talk about question number 27. So, talk about the DCD criteria, donor criteria. Question number 27. DCD, it is donor after circulatory death. Now, let's talk about their categories. We have categories on one hand and the description on the another one, right? So, we have category 1, which is dead on arrival. Category and criteria. We have category 1, which is dead on arrival. Which is dead on arrival. Then you have category 2, which is resuscitation attempted without success. We have resuscitation attempted without success. But this is in ER. In emergency room. That is category 2. Category 3 is awaiting cardiac arrest. Awaiting cardiac arrest after withdrawal of life support. After withdrawal of life support. After withdrawal of life support. That is category 3. Category 4 is cardiac arrest after brain death or while the patient is brain dead. While brain dead. Cardiac arrest while brain dead, that is a category 4. Category 5 is cardiac arrest and unsuccessful resuscitation in inpatient. It is cardiac arrest with unsuccessful resuscitation in inpatient. Right, so this is your category 5. Now we have something called as a controlled and an uncontrolled DCD donors. So when we say controlled, that means you can predict the death. So we have controlled DCD categories and uncontrolled and the uncontrolled DCD. and the uncontrolled DCD. Now, for an uncontrolled, it is category 1, category 2, and category 5, right? Whereas the controlled ones are category 3 and the category 4. See? So, when you go to question number 27, uncontrolled, as we have just learned, it is going to be 1, 2, and 5 category, that is C. So 27 is C for Calcutta. It is C for Calcutta. Okay. So question number 28. Let's look at question number 28. I have a 33-year-old asymptomatic. I have a 33-year-old asymptomatic woman referred to the clinician for an abnormal finding on a mammogram. No masses are palpable in either breast. The mammogram shows a tight cluster of microcalcifications at 2 o'clock position in a left breast. Magnification compression view shows at least 20 tiny irregular calcification in a 2 centimeter area that vary shape and density and not associated mass lesion. There is no other calcification present in the either breast. What is your next appropriate step? Now, remember, presence of microcalcification is a variant feature of lobular carcinoma in situ. The problem with LCIS is it is a pre-malignant condition. It is not a malignant condition, but it has got a very high propensity for developing into malignancies, right? Now, when you're suspecting it to be a malignancy, how would you like to diagnose it? Because there is no mass, I need either you can go with wire localization, follow-up imaging, reassurance of benign pathology, and stereotactic biopsy. I will not reassure because I need to rule out the malignancy. That is one of the first and the foremost thing that is running in my head. Second, would you like to go with a stereotactic biopsy? The problem with a stereotactic biopsy that you need to analyze, that you need to localize the lesion, right? Why? See, for doing an excision, there has to be lesion. There's no excision, there's no lesion. I will not wait. Stereotactic, I have to localize with the help of a guide wire and then take a biopsy, and this is your stereotactic biopsy. So, for any in situ malignancies, you will go ahead with stereotactic biopsies. So, answer here is going to be D for Delhi. Question number 29. The SEEP classification in a formal system, that is, okay. Okay. Clinical picture, etiology of disease, anatomical pathophysiology, venous. A patient with a telangiectasia on a physical examination of lower extremity would be classified into which clinical staging? I'll look at the quickly looking at the clinical, that is SEEP classification. Question number 29. We are looking at SEEP classification, right? Now, in the SEEP, as C is clinical, E is etiological, A anatomical, P pathophysiology. Now, we have C0, there is no disease. Then you have C1, there could be presence of telangiectasia or may be associated with reticular veins. C2 is where we call patient is having varicose veins. If patient develops varicose vein after treating the first attempt, that is called as the recurrent varicose veins. We have the recurrent varicose veins. C3 is presence of edema around ankle. C4A, this is presence of pigmentation. C4B, it is your lipodermatosclerosis. C4C, it is coronophlebectatica. It is a coronophlebectatica. Now, C5 is your healed venous ulcer. C6 is your active venous ulcer. C6 or it is your recurrent venous ulcer. So in our question, we have telangiectasia, and telangiectasia is your C1 disease. Telangiectasia is your C1 disease. So 29, it is going to be your C1 disease, B for Bombay. Now, question number 30, which of the following hernias is most likely to reoccur after a primary repair? The maximum chances of recurrence is seen after your repair of incisional hernia. So, D for Delhi, right? It is going to be D for Delhi, right? Question number 31, identify the knotting technique which is being provided here. Now, it's a very classical knot that you can see. Now, easy way to remember is, this is what we call it as a loop, right? It's a red loop that is present, and you see the blue thread is going under the loop, and both the threads are going under the loop. Here, you see, if this is the loop that is present, you see both the threads are going over the loop. So either both the threads are going under the loop or both of them are going over the loop. If that is there, this is what we call it as the reef knot, or also referred to as, alternately referred to as the square knot. So answer here is going to be A for Ahmedabad. Now, if you want to know how does a granny's knot look like, if you take this as the tissue, in a granny's knot, let's say this is one end of the thread which is like this, and let's say this. Now, in the granny's knot, you will notice that one side will be above, one side will be below. You will notice that one side will be above and one side will be below. Now, if you see here, green thread is above the red loop, and here on the other end it will be under the red loop. So this is up, this is down. Here red is up, here red is down. So one up, one down. This is your granny's knot. This is your granny's knot. But there has to be a test given on the Telegram group. No, we'll ask the team to coordinate. Now, when you talk about the surgeon's knot, now for a surgeon's knot, you will have two loops and one loop on top. This will go in this particular manner. This will be like this, right? So in surgeon's knot, you have one loop here, another loop here, and there's one more loop on top, right? So two loops bottom, one loop on top. Again, you will see this is down. Here also it is down. Here green thread, you see it is up. Here also it is up. So it's almost like a reef or a square knot where you have both the threads going above, but again two loops down, one loop on top. This is your surgeon's knot. Half hitch is a single loop. So a half hitch has to be created. It has to be like this. For a half hitch has to be created, it has to be like this. That's it. A single loop is what we call it as a half hitch. So this is your half hitch. So you have the reef or the square knot, the granny's knot, the surgeon's, and the half hitch knots, right? So answer here is A for Ahmedabad. Now question number 32. All of the following statement regarding the image shown is true except. So what is this? This is a central line. This is an image of a central line, popularly known as Hickman's line. Popularly referred to as the Hickman's line. And this Hickman's line is also referred to as a tunneled subclavian vein central line. Now just to understand, this is the subclavian vein that is going across here. On the other side you have, this is the subclavian vein that is coming. Together they open into superior vena cava. This is the access point that you have. Now you can take the access directly into subclavian vein like this, right? But the problem is, again, the probability of, line ejection, all these are more common. To avoid this, you have a better option, and that is your Hickman's line. Now in the Hickman's line, you take the entry point here. The catheter is buried into the skin, and from there you come out and then you insert directly like this. So you are creating a tunnel under the skin, and this is what we call it as tunneled central vein access, right? Now, all of the following are true except, remember, used for long-term TPN or parenteral nutrition. That is absolutely correct, because if you are using, okay, in terms of TPN, central lines are used if you are planning to feed for more than 2 weeks. If there's more than 2 weeks of feeding required, then I'll be using central lines. Less than 2 weeks, I'll prefer PICC, that is peripherally induced central catheter. Known as the tunnel central line, this is also correct. The reduces the risk for line dislodgement and line sepsis, correct. Chest X-ray, it is required. After doing all central lines, chest X-rays should, or an ultrasound should be performed to confirm the position of the line. Otherwise, it is incomplete. And obviously, this scholar loss, you need to be confirmed whether it is in the central axis or not. So hence, D is the wrong answer. Right. Question number 33. A 52-year-old female presents with the complaints of difficulty in talking, breathing, swallowing. Okay. Oral examination, a swelling is noticed between the circumvallate papilla of the tongue and the epiglottis. So right now, I have the diagnosis of ectopic thyroid gland. Probably it could be an ectopic thyroid gland. Okay. Now on radioactive iodine uptake, it shows a positive uptake, telling you it is a ectopic thyroid gland. Which of the following is the most common site for the above case? Remember, for ectopic thyroid gland, it is most commonly seen in sublingual. It's a sublingual, right? So subhyoid, suprahyoid, juxtahyoid is for thyroglossal duct cyst. The last option that you have is lingual. Answer here is going to be D for Delhi. Do not make the mistake by looking at the option, because most of the students would answer for thyroglossal duct cyst, which is a remnant of your thyroglossal duct itself, right? Now, for ectopic thyroid glands, the management, if it is a solitary, you have to go with suppression therapy. If it is multiple, we have to go with excision. For thyroglossal duct cyst, we will go ahead with Cis-Strung's operation, as simple as that. So you say subhyoid is the most common site. It is the most common site for thyroglossal duct cyst. And the surgery of choice, there is going to be Cis-Trunks operation. So answer here is going to be D for Delhi. Question number 34, we are talking about retroperitoneal hematomas following trauma. Which of the following statements are true? So you need to talk about the zones of retroperitoneal hematomas. Question number 34. Retroperitoneal hematoma. So when we talk about the retroperitoneal hematomas, let's say this happens to be the retroperitoneal space. Now, what we divide is, we divide the retroperitoneal space into central zone, which is here, then into the lateral zone, which is present here, and the rest is considered to be as the pelvic zone. So they are divided as, this is zone 1, This is zone 2. And this happens to be your zone 3. Okay. Zone 1 is also referred to as central zone. Zone 2 is what we call it as the lateral zone. And zone 3 is your pelvic zone. It is going to be a pelvic zone. So zone 1 is central, zone 2 is lateral, zone 3 is going to be pelvic. Now remember, whenever there is presence of hematoma, if there is presence of hematoma in zone 1, the guideline says always explore. Whereas if there is presence of hematoma, in zone 2 and zone 3, and if this hematoma, number one, if it is either expanding, if it is an expanding hematoma, or if it is a pulsatile hematoma. If it is expanding or a pulsatile hematoma, this is the indication for exploration. This is an indication for exploration, or else you can leave it. Okay? So, going back to our question number 34. Now, which of the following statements is true? Penetrating trauma in pelvis must be explored. No, only if it is pulsating or expanding hematomas are there. Zone 1, embolization of injured vessels. Zone 1, you have to always explore the zone 1 where you have big vessels. Right? The aorta or the IVC is the source of bleed. I will not go for embolization. Zone 3 hematoma should always be explored surgically. No, only when they are expanding or pulsatile. Mattox maneuver to explore aorta involves all structures to be turned right, and that is correct. So answer 34 is going to be D for Delhi. Right. Everybody knows, no, we have the mattox, we have the two components that you have, the cattle brush, the mattox, and the coccus, right? So I'll just add there only. We have mattox, we have the cattle brush, and we have the coccus. Now here, entire bowel, or as we call it as the left medial visceral rotation. Cattle brush is your right medial visceral rotation. And this is to lift the stomach. Coccus is to elevate the stomach or lift the stomach. This is to expose retroperitoneal space. Chalo. Okay, question number 35. This is what we call it as the circular stapler. Now the question says, which of the following is not true? Now remember, circular staplers can be used, or it is basically used to perform an end-to-end anastomosis. We can use to make an end-to-end anastomosis. It can be used to perform hemorrhoidectomy. And complete donut. Complete donut is the hallmark of, it is the hallmark of completion. Complete donut is the hallmark of, or I can say this is the most reliable or hallmark of procedure completion. Right? Okay. Now it is used for esophagojejunostomy, which is an end-to-end anastomosis. So this is correct. Used for hemorrhoidectomy is correct. Completeness of procedure is confirmed by donut of excised tissue, correct. It can be used for end to side. No, it is only used for end to end. So D is wrong. So again 35, the answer is D for Delhi. It's going to be D for Delhi. Now question number 36, again a very important component. So far any doubts, any questions, quick feedback? So let's look at the next question. So we're talking about all of the following are the factors. All of the following are the factors preventing the spontaneous enterocutaneous fistula closure except, right? Now when you talk about the enterocutaneous fistula, it is divided on the basis of output. You have the high output, we have the moderate output and the low output. Low is less than 200 ml in 24 hours. Moderate is 200 to 500 ml in 24 hours and high is more than 500 ml in 24 hours. This is the output. Now high output, it is the one that is going to be against closure. So low output can be closed, moderate can be closed, high output, it is this, if there is a high output enterocutaneous fistula, it is not possible to have a spontaneous closure. So all of the following are the factors preventing except output of more than 200, it is not preventing. Radiation, yes, it prevents. Epithelialization tract can prevent, and undrained abscess cavity can prevent. So answer is A for Ahmedabad. It is the high output enterocutaneous fistula which prevents the spontaneous closure. Now question number 37, according to the suggested simplified system of European hernia system, a primary indirect inguinal hernia of 3 centimeters. Now this system has given you a very simple component. Either it has to be primary or secondary. So P is primary, S is secondary. Then you have L stands for lateral, M stands for medial hernias or midline hernias. You have the lateral hernias or the midline hernias, right? And then 1.5 centimeter defect is equal to 1 finger breadth, right? So a primary hernia, which is lateral, means your inguinal hernias. Medial is going to be your ventral hernias. This is going to be your ventral hernia. Lateral is going to be inguinal, femoral and all. 1.5 centimeter defect is called as 1 finger breadth. So you have primary, that is P. So if I simplify this, this is primary is P. Indirect inguinal hernia is lateral. 3 centimeter defect, 1.5 centimeters 1 defect, 3 centimeters is going to be 2. So PL2 will be the answer. So C for Calcutta, right? So it is going to be C for Calcutta, that is your PL2 will be given. Identify the structure marked in the image. So if I decode this for you, now this is basically your triangle of doom. If I simply give you the idea behind it. Right. So this is the triangle of doom. You see here, this is your deep inguinal ring. This happens to be your deep inguinal ring. This is the medial side. This happens to be the lateral side. You see this which is present here. This is your pubic arch, right? This structure that is present, which is reflected down, this is the peritoneum, which is reflected down. Medially, you see this structure which is present. This is your vas deferens. Laterally, you see these are your gonadal vessels. These are gonadal vessels, and this is the triangle of doom. right? So triangle of doom, the structure that is marked is going to be your vas deferens. So answer here is going to be B for Bombay. It is your vas deferens. This is your triangle of doom. So quickly looking at question number 38. So the triangle of doom, and then you have triangle of pain. Now if you look at the whole component, this will be the abdominal wall, which you look across here. This happens to be the fascia transversalis, which is the innermost component. See, this is the midline we're talking about. Now, there's a defect in the fascia transversalis, and this defect is going to be your deep inguinal ring. Right. Now, you see the vas deferens is going to come from the superficial inguinal ring, goes to deep inguinal ring and turns medially. So, this is your vas deferens. On the lateral side, you see there's a vessel that is running here. This is your gonadal vessels, and this is the peritoneum that you have reflected down, right? So once you reflect down the peritoneum, this is the peritoneum that is present, just for the sake of understanding, right? Now this is what we call it as the triangle of doom. This is what we call it as the triangle of doom, and this is what we call it as the triangle of pain, right? So the triangle of doom, if you talk about the boundaries, so this is the triangle of doom, this is the triangle of pain, right? In the triangle of, this is your deep inguinal ring, this is your vas deferens, this is your peritoneum, this happens to be your gonadal vessels, this is your iliopubic tract. So if you say what are the boundaries, medially, so this is the medial side, this happens to be the lateral side. Medially it is formed by vas deferens, laterally gonadal vessels, inferiorly by peritoneum. The component that you have is your external iliac artery and the external iliac vein. Triangle of pain, it consists of various nerves. Remember, most common nerve injury in laparoscopic hernia repair. In laparoscopic hernia repair. In the laparoscopic hernia repair is your lateral cutaneous nerve of thigh. It is a lateral cutaneous nerve of thigh. It is the lateral cutaneous nerve of thigh. See? So question number 38, the answer is vas deferens, right? Now, question number 39. Now, again, traumatic injuries are important. We're talking about the blast injuries. Now, in the blast injuries, match the following. Now, you need to understand when you talk about blast injuries, primary blast, what is secondary blast, what is tertiary, and what is quaternary blast. Now, the primary blast, whatever injury occurs, that is because of the impact. It is because of shock wave impact. Secondary blast or the secondary injury that occurs is because of whatever the component, let's say a bomb blast and there's a lot of shrapnels coming out. So whatever is the outcome of that blast. So it is because of injury due to sharp projections. Tertiary blast, the tertiary blast is going to be because of blunt force, and the quaternary is because of the burnt area. It is going to be because of the burn that is going to be created. So primary blast, if I have to number them, let's say this is A, this is B, this is C, this is D, this is 1, this is 2, this is 3, this is 4. Now, A has to be, okay, shock wave is over pressure, so A has to be 2. Then you have B is going to be 3. B is going to, C is going to blunt force is where? Okay, 1 and 1, 2, 3, last is 4. So A2, B3, C1, D4, that is going to be B for Bombay. Answer here is B for Bombay. 39 is B, that is B for Bombay. Clear? Chalo. Now, question number 40, again, quite a big question, but the answer is going to be pretty simple, right? Now, we have a 63-year-old woman. We have a 63-year-old woman, unresectable cholangiocarcinoma, undergone a palliative therapy, presence with fever, right upper quadrant pain, okay, jaundice and cough for 1 day. Temperature, there's fever present, tachycardia is there, blood pressure is fine, respiratory rate is slightly high, saturation is fine. Physical exam shows there's soft and non-distended abdomen with tenderness in the right upper quadrant and hepatomegaly is there. Lab result WBC is elevated, ALP is elevated, chest X-ray shows an elevated right hemidiaphragm, right lower lobe atelectasis. Ultrasound is performed showing a round hypoechoic lesion within the liver with a well-defined border and several internal echoes. Now, mildly distended intrahepatic bile ducts and no cholestasis or pericholecystatitis is noticed, which is the appropriate management here. So, we are talking about, so what is the diagnosis here? Now, forget about everything that you have read. Here, I have a patient with cholangiocarcinoma, so there is bile duct obstruction. Whereas there is bile duct obstruction is there. Along with bile duct obstruction, what do you have? Elevated WBC count, elevated alkaline phosphatase, right? And then you have features suggestive of infection, right? So there is fever and all that. No? There's presence of fever, there's presence of pain, right? Is there jaundice? Okay. More importantly, on ultrasound, there is presence of internal echo. Now, presence of internal echo indicates that it is an infective etiology. So, what is your diagnosis? Elevated ALP with liver infection. It is only possible in pyogenic liver abscess. Remember, the most common organism is going to be E. coli and Klebsiella. So, this is a true infection. You have to go with drainage of the abscess and cover with antibiotics. Answer here is going to be B for Bombay. B for Bombay, it is going to be an pyogenic liver abscess. You have to drain the pyogenic liver abscess, right? Okay. Question number 41. A 28-year-old asymptomatic white woman incidentally found over 3.5 centimeter hypervascular lesion with a central scar in the right lobe of the liver. Now, the central scar in the right lobe of the liver, the central scar is seen in focal nodular hyperplasia. It's a focal nodular hyperplasia, which is FNH. Okay, continuing. On delayed images, there is increased uptake of contrast material scar in comparison with the surrounding liver parenchyma. She is otherwise healthy, takes no medication. Liver enzymes and AFP are normal. Which of the following is the most appropriate management in this patient? Remember, if it's a proven focal nodular hyperplasia, the only thing that you have to do is going to be observation. You don't need to do anything more than that. So, answer here is going to be C for Calcutta. If it is a hemangioma of the liver, less than 5 centimeters, observation more than 5 centimeters, enucleation, focal nodular hyperplasia, diagnosed case, nothing to do. If it is a hepatic adenoma, less than 5 centimeters, observation more than 5 centimeters, we are going to go with excision. Question number 42. We have a right upper quadrant abdominal pain develops in a 25-year-old woman taking an OCP. Okay. CT demonstrates a hypodense 6 centimeter mass in the right lobe of the liver. Technetium 99 scan reveals a defect in the area of the mass, that is technetium uptake is there, that is possible in an infective lesions. Angiography reveals an hypervascular tumor with a peripheral blood supply. Okay, which of the following is the appropriate management? So here we have OCP that is present. When you look at the whole component, it's a hypervascular mass. We're talking about the hemangioma of the liver. We're talking about the hemangioma of liver, right? Now, in the hemangioma of the liver, the concept is very simple. If it is less than 5 centimeters, observation, more than 5 centimeters, you'll go with enucleation. So here the answer is going to be 42. I do not have an enucleation as an option. I will not see again. OCPs and hemangiomas do not have a relation. It has been proven. It's a vascular tumor. I will not go with biopsy. I will not go with arterial embolization because the feeders are not extensively felt. So either hepatic resection, the better answer would have been enucleation because the diagnosis is hemangioma of the liver. Answer here is C for Calcutta. It is going to be C for Calcutta. Question number 43. What do you have? A 50-year-old woman, hypertensive, presents to you with right upper quadrant pain and jaundice. Okay. Palpable soft mass along the liver edge. Workup is negative for hepatitis. Ultrasound shows a 4 centimeter cystic structure in the extrahepatic and separate from the gallbladder. Okay. ERCP is performed and demonstrate a biliary diverticulum obstructing the common bile duct. What is the most appropriate step in the management? Now, because it's a series of congenital choledochal cyst. For a congenital choledochal cyst, the answer has to be an excision. So for 43, the answer is going to be resection, right? So here patient has pain and jaundice, right? And then you have a biliary diverticulum obstructing the CBD. You have to go ahead with resection. Again, it increases the risk of cholangiocarcinoma. That is an objective that we need to look across. Question number 44. Again, interesting question. 55-year-old women, history of colorectal cancer 10 years ago, treated with right hemicolectomy and chemotherapy. With no evidence of distance since then, temperature is fine, pulse is fine, blood pressure is fine, saturation is absolutely fine, all the other parameters looks common. CEA is slightly elevated. The triple phase CT shows a new peripheral liver mass that slightly enhances on arterial phase. She has hypertension, which is controlled with medication. What are the most likely diagnosis and the most appropriate management of liver lesion? Now, even though you have resected the colorectal cancer, it can arise from another site and then it can cause liver mets. Remember, most common site for colorectal metastasis is going to be liver. The answer still remains here is D. That is your metastatic colorectal. You have to go with resection. Remember, liver mets in colorectal cancer is not a contraindication for surgery. You can go ahead with metastatectomy. In fact, one of the most important is presence of peripheral masses. Remember, metastases are going to be peripheral, central or primary. So here you will go ahead with resection, right? Question number 45. A 40-year-old man, alcoholic cirrhosis, increased abdominal distension in last 1 month, vitals stable, afebrile. Physical examination reveals as abdominal distension with a fluid wave. The initial management of patient's ascites should include all of the following except. Remember, when you talk about TIPS is done for refractory ascites. It is done for refractory ascites, not as soon as you see ascites. So if you have done everything and the ascites is not responding, that is when we do TIPS. Otherwise, there is no other rule. Right. So answer here is A for M. The word TIPS is done for refractory ascites, not for initial ascites. Question number 46. A 63-year-old female undergoes a laparoscopic cholecystectomy for symptoms of cholelithiasis. Pathology states there is a foci of carcinoma that invades but does not penetrate through the lamina propria. What is the most appropriate management? Now, this is one question that we will get again and again. We need to be prepared for the management, right? So, we're talking about the management of gallbladder cancer. I'll just quickly take question number 46. So talk about the question number 46. So management of gallbladder carcinoma. So it is basically a T-based management that you have to look across. Now, so we'll talk, I don't want to go into the entire spectrum, but we'll try to keep it simplified for you. Now, if you have a patient who is having a T1A disease, we'll see if it's a T1B disease. If it is a T2 disease, is it a T3 or a T4 disease? Now, what is a T1A disease? Remember, T1A disease, if it is involving lamina propria, T1B disease, if it is involving the muscular layer, T2 disease, you have two components here, T2A, T2B, but if it is involving perimuscular connective tissue, involvement of perimuscular connective tissue, that is T2. T3 is going to be local invasion. T3 is your direct invasion, and this direct invasion of liver, extrahepatic bile duct, stomach, duodenum, liver, extrahepatic bile duct, stomach, duodenum, or pancreas, or omentum, or in that matter colon. T4 is involvement of portal vein, involvement of hepatic artery, or more than or equal to 2 extrahepatic organs. Now, how would you like to manage based upon this? Remember, T1A disease. For a T1A disease, I will do a simple cholecystectomy. We'll do a simple cholecystectomy. For T1B and T2, we do radical cholecystectomy. For T3 and T4, we will try neoadjuvant chemotherapy, which is gemcitabine, and then followed by surgery. And that too only if there is a response is good, right? So this is the component that you have to look across. Now, so question number 46. What will you do? Here it is involving lamina propria. Involvement of lamina propria, as I told you, it is going to be T1A. For T1A, only cholecystectomy is more than enough. So answer here is going to be C for Calcutta. It is going to be C for Calcutta. Question number 47. I have a 73-year-old female with acute onset of abdominal distension, pain, nausea, and vomiting. Okay. She has no previous surgeries, no abdominal or inguinal hernias. X-ray is given, air fluid levels and pneumobilia is there. Obstruction is most likely at the site of. Now, a classical case of gallstone ileus. So this is your classical case of gallstone ileus. Now, in a gallstone ileus, you have a triad, that is what we call it as the Regulus triad. Now, what is the Regulus triad telling you? There is a small intestinal obstruction. There will be presence of pneumobilia and presence of ectopic gallstones. Remember, the most common cause for gallstone ileus, it is because of bilioenteric fistulas. It is the bilioenteric fistula. The most common site for this bilioenteric fistula, it is between the gallbladder and the duodenum. That is your cholecystoduodenal fistula. It's a cholecystoduodenal fistula. And remember, the most common site for obstruction, it is going to be your terminal ileum or at the ileocecal valve. It is at the ileocecal valve because that is where the obstruction goes and stops. So answer to the question number 47 is going to be D for Delhi. That is your ileocecal valve, right? This is with respect to gallstone ileus. Question number 48. 71-year-old female presents to your office with high output biliary fistula for 3 weeks after you have performed a subtotal fenestrating cholecystectomy with subhepatic Jackson-Pratt drain placement. Okay, for acute cholecystitis. She is asymptomatic. What is the next step in management? Remember, if there is a high output fistula, the continuous drainage is occurring, you have to know and localize the site of obstruction, site of the component. So you have a patient who is having a high output biliary fistula 3 weeks after you have performed a subtotal cholecystectomy, right? Now the subhepatic Jackson-Pratt is for acute cholecystitis. Okay. Now she is asymptomatic. What is the next step in the management? Localize the site, and that can be done with the help of ERCP. So answer here is going to be A for Ahmedabad. That is going to be ERCP. Clear? Chalo. Question number 49. We are in our penultimate question. 46 years old male, 2 days history of right upper quadrant pain. WBC is elevated. Ultrasound numerous gallstones. Wall thickening, pericholecystic fluid is there. On examination, slightly febrile. What is the Murphy sign is positive? Best management. If he is presented within 72 hours, I will do an early laparoscopic cholecystectomy. There is no question in that. If he presents beyond 72 hours, then I have to go with conservative management. As simple as that. Question number 50. That's the last question. A 58 years old woman with jaundice underwent an ERCP for a diagnostic work. This is the radiograph. What is the most likely diagnosis? You can see this is a very classical sign. Right? This sign that you're seeing here, this is what we call it as the double duct sign. In the double duct sign, you see this duct that you see, this is going to be your biliary system, and this is your pancreatic duct. And this is usually seen in pancreatic head malignancies. It is usually seen in pancreatic head malignancies. So it is your pancreatic carcinomas. So B for Bombay, double duct sign is seen in pancreatic cancers. What are the other signs that you see here? You can see an inverted 3 sign, you see a double duct sign, your widening of the C loop of the duodenum, right? So what are the other things that you see? You will also see inverted 3 sign. You see an inverted 3 sign. You have widening of C loop of duodenum. There is a widening of C loop of duodenum, right? So answer here is going to be pancreatic cancer. For chronic pancreatitis, if you do an ERCP, you will see what are the signs in chronic pancreatitis. You will see chain of lakes appearance. Chain of lakes, or also called as string of beads. String of beads appearance, right? So answer here is going to be B for Bombay, right? So this is all that you should know in the context of T&D. That's the first set, that is first 50 questions. Tomorrow we'll meet you again at 2 o'clock, repeating the same series again. So we have another 50 questions to discuss tomorrow, and based on that, if you have any questions or queries, we'll take across, right? With this, I am going to sign off for today. We'll resume back tomorrow. Thank you, guys.